29.
The meeting, just reminding members again, please, the meeting's held in public session, and recording mobile phones and Blackberries will interfere with the recording, so please asking members to switch off the phones. I have apologies from David McElveen. A number of items under Chairperson's business. I want to remind members that the committee will be visiting Queen's University, the Centre for Cancer Research and Cell Biology next Wednesday morning, starting at 10:15 a.m. Transport has been arranged from here, leaving at 9:45 a.m. So if members indicate their attendance to the committee staff. I want to advise members that a follow-up event to the Emergency Care Summit was held on Monday. The Minister has issued a press release which states that the College of Emergency Medicine has produced draft recommendations and an action plan. I would suggest that the committee writes to the department to seek a copy of these recommendations and action plan. I also want to refer members to correspondence from Fergal McKinney, which is at page 3 of the tabled papers. This concerns the Legal Aid and Coroner's Court Bill, which is currently being dealt with by the Justice Committee. The Attorney-General had written to the Justice Committee to seek an amendment to the bill, and the Justice Committee has taken evidence from the Attorney-General on the matter. It also wrote to the Department of Health on the proposed amendment, and this committee was copied under the response. It's my understanding that Justice Committee are doing formal clause by clause consideration of the bill this afternoon, and will finalise the report next week. Therefore, in terms of this committee's role, the time has passed in that sense for this committee to become involved in the bill. I would, however, remind members that any private member can table an amendment to the bill at consideration stage if they so wish.
I'm nipping into Justice to do exactly that. Are Justice aware of these concerns? Is the Justice Committee aware of it? It may be we see the committee's got the power to draft an amendment even at the clause-by-clause stage if it's so important. Or is it an issue that they have even consulted on? I'm
being advised by the Clerk that Justice are aware. Do you want to maybe comment on that?
Yes, my understanding is that the Attorney-General had written to the Justice Committee quite a long time ago with this proposed amendment, and has also come and discussed this with the Justice Committee.
Are they aware that Fergal has taken it up? That's the issue, and I know they're aware of it in that sense, but I wasn't aware until today that Fergal had raised this issue. Obviously, there's potential of a private member's amendment coming in. We're going to have to consider that at this stage if we get warning of it. Have you written to Justice in this, Fergal?
No.
Right.
No. As I understand it, the Attorney-General has presented to the Justice Committee proposals that he thinks would be helpful in relation to scrutiny of hospitals.
Yes.
All I'm looking for, and maybe you're seeing it's going slightly further, all I'm looking for is the Attorney-General to come and talk to us about those proposals and the general issue. He's proposed specific things that he thinks would be helpful in relation to the Legal Aid and Coroner's Courts Bill. But there are issues, I think, that spill out into this remit that are of concern. And I mean, of course, the Justice Committee may take it up, or the Justice Committee may not take it up. But I think these are issues of fundamental concern for us, because what we're witnessing here, and I have some major concerns around how the Health Service is going to handle the issues of the 20 deaths in the Northern Trust area. The Trust will be the first body to examine those SAI issues. And only afterwards, once their findings have been collated, will that be presented to other authorities to have a look at. So that's an issue for me of hospitals investigating hospitals, or hospitals investigating hospital deaths. And the Attorney-General has things to say about that, and the wider issue of scrutiny that I think this committee should not close its ears to. And I think it would be helpful for us to have that meeting, whether it fits in with the timetable of the Legal Aid and Coroner Courts Bill or not. I think these are important issues that we should consider. And unfortunately, some of this has happened hastily. And I apologise if that has alerted you in another way, if you like, to something. I just want this discussed, and I think it's an important thing for the committee to consider.
Okay, I think it is. I mean, the issues you raise are of obvious interest of the committee, absolutely. I think it would be appropriate if we sought more advice, maybe, Fergal, with your permission, through the committee clerk. I'm just conscious that this is two separate committees, and within our protocol, we need to be correct, but we need to do the right thing as well. So maybe if we park this at this stage and sought more advice in terms of what the committee's role would be with the Attorney General, given that Justice are already going through a formal clause-by-clause consideration, and bring that information back here.
In its widest sense, Chair, I appreciate that. All of these issues need, if they're to be furthered, some sort of political consensus. And all I'm looking really is for the Attorney General to have the ear of the committee at this point, for him to discuss with us what his concerns are, so that we're better informed. And that if it doesn't happen through that mechanism, what mechanisms could we be looking at in terms of bringing that sort of level of external scrutiny to what is a very big issue in terms of accountability and transparency?
No, absolutely. I don't think anybody would disagree with that. I think it's about the process that we can use and for what purpose. But if we can reflect more on that and bring that back, I don't think anybody would be opposed to having the ear. But I suppose it's using our protocols, bearing in mind what Justice are doing. So if we're comfortable to park it at this stage, reflect on it, see where best we can fit in terms of our protocol, and come back to it.
And I'd be happy to do that. I'm not looking to pressure, but obviously not something that's parked in a long-term car park.
No, I'm only suggesting this week. Yeah, that's what I'm talking to Clerk just in terms of next week. Also, under Chairperson's business, two other items I wanted to just make reference to. The presentation this week from the Green Investment Bank. There's a particular case study in Cambridge in an NHS hospital where there was a particular amount of investment, I think 18 million, in terms of, I suppose, green and profitable procedures within the hospital estate, which ultimately saved the hospital there upwards of £1 million every year. It's certainly something that, in my view, the Department of Health should be exploring in terms of opportunities. So I'm seeking approval here that we write to the Department to ask what engagements they're having with the Green Investment Bank in terms of the health estates.
Just to add to that, Chair, the Enterprise Committee yesterday held an event in the Long Gallery in relation to all of that, and a significant number of senior procurers within the service, the health service and other services and civil service were there. So some of that is coming through the system. I
think it would be appropriate that this committee just sought that update from the department. The other issue is in terms of muscular dystrophy, and I know there was some members of the all-party group, and again it would be to seek from the department an update on the recommendations that came from the McCallum report some time ago, just to get a sense of progress. I think there was in the region of 11 recommendations there, so if we could seek that in writing from the department, it would be useful. Moving on, members, to the draft minutes of the meeting of Wednesday the 4th of June. They're on page 6. Are members content with the minutes?
Great.
Thank you. Item 4, members, is a review of TYC and older people. It's the evidence session with officials from the department, the Department of Health and the Department for Social Development. I want to refer members to a memo from the committee clerk on page 12 and documents relating to the committee review on pages 22 to 173. Referring members also to a briefing paper from the department on page 5 of the tabled papers. And I'm also asking members to note a response from the Western Trust regarding spending by the Trust on supported living, which is on page 12 of the tabled papers. I'm just letting the folks. Folks, you're all very welcome. Just to outline today, we have Sean Holland, Deputy Secretary, the Department for Health, Mr Michael Sweeney, Acting Director, Mental Health, Disability and Older People, Finola McAndrew, Acting Chief Executive, Health and Social Care Board, Mr Stephen Martin, Deputy Director of Housing Policy Delivery from the Department of Social Development, and Mr Brian O'Kane, Acting Assistant Director of Strategic Partnerships in the Housing Executive. So again, you're very welcome. Just to advise yourselves that there's a number of key areas and key issues that the committee wants to discuss with you today. We want to work through each issue in turn, and we really want to use this as an opportunity to understand what the Department of Health and indeed the Department of Social Development's position are on these issues before we would make any recommendations in our report going forward. So we would really welcome an open and constructive debate, which we normally do have. So if I could ask yourselves to make a short opening statement, and then we'll open it up to members.
Thank you, Chair. And thank you for the opportunity to give you evidence on supported living for older people. I'm aware that the committee was disappointed that we weren't able to give you answers to some of your questions in the last session on the 26th of February, and that you've subsequently written to the department, and we've provided you with further information on a few occasions. Today I'm joined by Michael Sweeney, Fionnuala McAndrew, Stephen Martin and Brian O'Kane, and I think the number of witnesses that we've brought today reflects the range of roles and responsibilities across government and agencies with regard to supported living. I'm aware that one of the main issues for the committee to date has been a definition of supported living. The Minister's letter to the committee on the 28th of April advised that the definition was under review. The DHSPS, the HSC Board and the Housing Executive met in April to discuss the scope of the definition. As members will be aware from Professor Tinker's evidence to the committee, there isn't an agreed definition within the UK. There isn't a fixed definition within law within the UK. Currently, we're in the position of trying to reach a common understanding as to what a useful definition would be for supported living. As set out in the briefing paper shared with you at the end of last week, we currently consider supported living to be a term which encompasses a range of health and care provision, health-related adaptations, housing accommodation and housing support services designed to help vulnerable people retain their independence in their local community. Supported housing is one key supported living option. Supported housing relates to accommodation provided for vulnerable people who require housing support and or an element of care, and is intended to help individuals lead as independent a life as possible in their own home. Supported housing can vary in type and nature, and it can be designed to meet very different levels of need, and I believe that this might have been some of the cause of confusion regarding the extent of provision of supported housing. In our previous evidence session, the committee was advised there were 414 schemes for older people, while the HSC trusts at a subsequent session indicated a much smaller number. If I could take this opportunity to clarify that point, the 414 schemes represent the entirety of supported housing schemes for older people in the social rented sector. Sheltered housing, which is managed by the Housing Executive and housing associations, make up the majority of the 414 schemes and is intended for people who remain relatively independent but may from time to time need to avail of support, normally available from a scheme supervisor, or as some people might be familiar with the term as a warden associated with such a scheme. It should be noted that there haven't been any new developments of sheltered housing for some time. In recent years, trusts have identified a need which is more specialist in nature. Given this, the focus for new build social housing for older people has been on frail elderly schemes. These are facilities which the Trust reported on and are designed for people who need greater levels of support to remain independent. This will include help with personal care, tasks such as dressing, eating and bathing, all of which are provided or arranged by the HSC. There are currently 18 schemes in Northern Ireland. 2 of these have been completed during the comprehensive spending review period, Cedar Court in Downpatrick and Hemsworth Court in Belfast. Planning for such supported housing schemes take place within 3 to 5 year periods, with the current period ending in March 2016. The number of proposed developments is driven by trust assessment of demand as part of ongoing service delivery. Within the current planning period, there are plans for a further 7 facilities, one of which is Curran Court in Ards, and is scheduled to be ready at the end of this month. This is a process which we consider to have worked well over the last number of years. But we also recognise that there may be a potential for a centrally established target to drive the number of future developments, and that's why we've established an indicator of performance for supported living for older people this year. Notwithstanding the need for an agreed definition, we would contend that the central purpose of supported living is commonly understood. Similarly, we would be of the view that the roles of respective stakeholders within the Supporting People programme is understood, as outlined in your paper. To summarise, trusts have a responsibility for identifying need for new supported housing and developing business cases which are then considered through the Supporting People commissioning arrangements. Trusts also provide funding for any social care required for tenants of supported housing schemes. DSD, through the Housing Executive, provides grant funding of up to 70% of the build cost to housing associations. Housing associations then project manage the construction of supported housing schemes for social rent and become the landlord of the scheme once it's been built. Housing associations then either manage directly the housing support services to tenants or contract these out to specialist support providers, usually in the voluntary or community sectors. The Housing Executive, through the Supporting People programme, provides funding for housing support services, including those in supported housing. These services are designed to help people develop the skills and confidence necessary to live independently without support or to maintain independent living with ongoing support. At the beginning of the year, the Ministers of Health and Social Development met with officials and the Northern Ireland Federation of Housing Associations to discuss the future of supported living for older people and other client groups. The Ministers subsequently asked officials to arrange a workshop in February with key stakeholders, including both departments, the HSC Board, each trust, the Housing Executive and representatives from the Federation of Housing Associations. The workshop was very helpful in identifying a number of areas where improvements could be made, some of which are listed in your briefing paper. Going forward, both departments are in discussions with potential funders regarding a number of projects on supported living for older people. We're not in a position to discuss the detail of the funding arrangements at this time, but the work, if we are able to secure the funding, would include a project to identify and develop appropriate future models of supported living for older people, including those with dementia, and people with physical disabilities. This work would take into account factors such as geography, needs, including care, affordability, and assistive technologies. It would also include an assessment on whether existing models, particularly sheltered housing, are being used effectively and for the purposes intended. The study would also highlight situations or client needs for which supported living are not appropriate. Also, a project to identify any lessons learned from legacy or existing supported living schemes. A small number of such schemes have run into financial difficulties due to places being unfilled. Voids would be the common term used to describe an unfilled place over a sustained period of time. The purpose of this project will be to identify and share lessons learned from the commissioning, design, construction and operation of these schemes, with a view to both identifying how these schemes can be made sustainable over the medium term and pinpointing lessons for future development. And finally, the piloting of a supported living champion to promote the benefits of supported living. Should we be successful in securing funding for these projects, this will enable us to address many of the concerns raised by stakeholders through the process initiated by ministers, as well as building on learning from the committee's own investigation. That concludes the evidence.
Okay, thank you, Sean, for that. Gordon had indicated first, so I beg your pardon.
All right, no problem. Thank you for your presentation. But could I ask how many, and in your words, older people, I prefer to refer them to as senior citizens, are able to live in supported living environment, and how many are too frail or too much in need of constant medical care to do so? Does this vary between board areas?
Between trust areas, the number of people who live in supported living varies between trust areas, but I wouldn't say that the definition is purely on a basis of frailty. As we said when we attended the last time, there are two components which will determine where someone lives in these kind of schemes. Firstly is an assessment of their need, but secondly, and most importantly, is choice. And it's a combination of those two factors, which is why exact projections can be difficult for the numbers, because you have to account for those people whose needs could be well met by supported living, as well as the number of people who would choose to live in supported living. And obviously that varies from individual person to individual person.
So, are you not giving any figures? Does this vary between board areas, the number of senior citizens?
There would be a variation between the number of people in
And you don't
supported
have those numbers?
Do we have the exact numbers by trust?
And by trust, in terms of the number of people who are currently in supported housing, currently in
Living
nursing
environment,
and
and how many
residential
are
homes.
too frail or too much in need of constant medical care?
Well, I suppose it's important to say that there are a range of services that are provided. So those people who need constant medical or nursing care would be assessed as needing and living in our nursing homes. And we have roughly, at the top of my head, about 5,000 places in nursing homes across Northern Ireland. I would need to add up the numbers of places here in supported housing at the minute in terms of the number of people who are actually currently living, but I think that was given in your briefing, the number of supported housing places that we have currently. So it really is a definition of need, and overlaying that, the number of older people who might be living in a locality, in a ward area or a trust area, the projected shift in the number of people who might live there in the future. And certainly there is a continuum of care need that needs to be addressed, and that's the purpose of the planning process, to make sure that we have those range of services that are available. But just briefly picking up Sean's point, one of the key issues about community care over recent years is that we discuss the care needs with people, and that they have some choice in how their care needs are met and delivered where that is possible. So you have seen a trend where people prefer to stay in their own home, or they prefer to live in an environment like a fold where they have their own front door and self-contained accommodation. But knowing shift in population, growing older population, long-term conditions increasing, the likelihood is that that cohort of people around the 5,000 places for nursing care will be needed into the future.
But you can't tell me how many are in each bracket that are living in...
I can tell you, but I don't have the
Okay,
cumulative figures in front of me, but I can send it to you. Yes.
Okay, thank you for that. Okay, and then there were specific themes, I suppose, coming from, as I said, Sean, coming from the work that the committee was doing, and one of the key issues, and you mentioned it, was the definition, and I think Roy wants to maybe lead on that.
Thank you, Madam Chair. The Trusts and the Northern Ireland Federation of Housing Associations indicated that they believe there's a very clear definition of supportive housing, and the definition that was in common use was that where there were supported living facilities for older people whose facilities were commissioned under the Supported Peoples Programme. It's very clear. So I'm just trying to understand, how has that definition suddenly changed?
I don't think it's suddenly changed. I think it's important to bear in mind, I mean, there are different types of definition. You can have a definition which is set out in legislation. That's a very strict definition that would clearly define entitlement or a legal description of something, and there is no such definition relating to supported living or supported housing. I think the other kinds of definitions are what people generally understand to be the case to describe it, and what you've given is a definition which they believe clearly describes it, and I wouldn't question that. I think there are other elements that you could include or exclude from that definition, and that's what the current discussions are about. What is a good working definition that everyone could commonly agree on? But I think substantively, and we've provided you with this in the briefing material, there is agreement as to what the core elements of both supported living and supported housing are. I mean, wouldn't my colleagues from DSD like to add to that?
Just in the housing strategy, facing the future, the definition that we've given you is the definition that we use. Supported living is an umbrella term for a range of services that are aimed to support people to live independent lives. One element of that is supported housing, but there are other things, as Sean has referred to, adaptations and so on, which support people to remain in their own home. So I don't think the definition that we've given is is at odds with the definition that the Federation of Housing Associations has given, or indeed the trusts, or indeed Professor Tinker, and who I believe gave evidence to you fairly recently, and what she calls extra care schemes, or what we've referred to as the frail elderly schemes. That's because that's what we call them. Sheltered housing is for those with lower support needs. So I think I think sometimes there are different terms used, but we're all talking about the same thing, and we have a common understanding across our departments and organisations. And I don't think it's at odds really with what you've been told before today.
Well, I think when you start to change the definition, it starts to cause confusion. That's my view, and I think the view of the public. Certainly, I think locally, if you talk about supported housing, you're aware in my constituency, one major location, Barnholt. There's other supported housing at Liscarroll, and then there's a number of sheltered housing accommodations. Now that's terminology is just all mixed up now. If this is actually put into play and is brought into, what was the purpose of actually changing the definition? And how can the committee have confidence in the department? And how can the department give trusts a clear policy direction in the area when before the review began it was working to a completely different definition of supported living than they were?
I don't think we are changing the definition. I don't think that there has been a fixed definition prior to this point in time. As I said, there are some situations where you have a very fixed legal definition, and sometimes those mirror phrases that are in common usage. I'll give you an example. If I was to use the phrase children in need to you, I'm sure you would have an understanding of that. Most people would. There's also a very strict legal definition of a child in need. And the position with supported living and supported housing is there isn't a strict legal definition. There is a common understanding as to what it means. Now, the work that's currently underway is to see whether or not we can make sure that we can reach an accepted definition that everyone finds useful. But I don't think that there's any significant evidence that the absence of a fixed definition is causing any difficulties. And indeed, Professor Tinker, I think, made that very point when she gave evidence to you.
My impression is you're trying to change what's commonly known as supportive housing to a new definition, frail elderly schemes. How easy do you think? Well, you're now calling what people would commonly know as a supported housing programme. You're now referring to them as frail elderly schemes. Is that correct?
Frail elderly schemes we would consider to be one possible expression of supported living.
So now what would previously be known as supportive housing commonly is going to be relabelled frail elderly scheme. Is that correct?
Can I maybe just clarify there? Supported housing, there are many types of supported housing. For older people, there are two main types of supported housing. There's sheltered housing, which many people know as FOLs, which have been around since the 70s.
Sorry, I have contacted the housing executive and asked, is there any supported housing in Larne? And they tell me no. They tell me there's sheltered housing in Larne, there are vacancies, we have no supported living in Larne. So how can you say what you've just said? Please explain.
I think it refers to the point that Stephen was making, is that under supported accommodation there are two main types. The sheltered accommodation, which most people tend to refer as FOLs and understand as FOLs. So there is provision of sheltered accommodation in the Larne area. In terms of supported accommodation, in terms of the frail elderly, the likes of the Barnholts, or hopefully what will happen in Green Island in the near future, there aren't one of those type of services, one of those type of projects in Larne. So I don't want to speak for the staff in the Larne area, but my sense is that what they're referring to is the sheltered accommodation, which they understand as shelter, and it's this common parlance about, as Sean said, about what they would understand that to be. They would commonly refer to it as a fold, even though there may be other housing associations delivering shelter accommodation. And then the issue for us is around defining understanding what the frail elderly service is, because the Barnholts and hopefully the services at Green Island that we plan to develop in the near future will be different from a shelter accommodation.
Certainly in the past that would have been referred to as supportive housing. But my next question is, that seems to be being relabelled. My impression is as frail elderly scheme. How easy will it be to convince an older relative that I want you to go into a frail elderly scheme as opposed to a supported living scheme? How easy do you think it will be with that label?
It's probably an unfortunate term. I mean, Sean,
I think it's a very
unfortunate term, and I think actually, that's something I think it's common parlance within the housing world among housing professionals. But I take your point, and I think we thought Professor Tinker's definition of extra care housing actually was quite a useful thing. We're talking about the same thing, but the terminology is probably unfortunate. No, I agree with that.
And finally, in terms of
change.
indicator performance that a number of older people living in supported living facilities are currently indicated and contained under the HSC Indicator of Performance Direction 2014. What exactly are the trusts currently measuring?
The trusts know the number of schemes.
Which schemes? I'm trying to be clear. What are they measuring at present?
Well, we will be measuring the 18
Oh, it's the 18 schemes.
supported living scheme. Yes.
Okay. And right. So that's different from what you're actually talking about in terms of this new definition. Is that correct?
The new definition includes those schemes. Well, we haven't actually arrived at a new definition at this point. I mean, I think the point is, reflecting the difficulty that you found when you contacted Larne Housing Executive, is that we're trying to work up a definition that everyone would agree and understand.
Yeah, we'd hope that the definition that were provided in the briefing would have been helpful. But as was said earlier, it's really, supported living is a generic term, an umbrella term. But in the briefing, then we detail underneath the various types of support provided, including the frail elderly schemes. So it's just a good working definition in the absence of an academic or legal one.
But something which I think will cause problems with those who wish to use the service. Final point, if I may, under future projections for supported living places, you have included those listed within the 3-year supported people's programme. Are there no sheltered housing programme planned within the 3 years if you've come up with this new definition?
I think in the briefing, reference was made to the current CSR period, and the focus has been on despite the definitional issues we referred to, focus on the frail elderly, the barn halts and the Green Island zones. We haven't planned to commission any new sheltered accommodation, but it's something we're talking to the Federation about going forward. We're looking at the future planning cycles coming out of it, and some of the work we referred to, that Sean referred to, and the things we want to do. We want to look again at the future role of sheltered housing. I think the important thing from a service perspective, and I take your point about the customer, the older people themselves, they need to be clarity about what they're hearing, what the offer is. So I take your point about the confusion of the issues. But what we've been focusing on is developing the barn halts and the higher level of service that goes with those services that you wouldn't get in a traditional sheltered scheme.
Can you understand why I'm getting confused when you don't even apply your own new definition within the document you provided us? Thank you.
Just on that, for clarity, we're saying that the definition's still being reviewed, Sean, is that what we're saying?
Yes, there's work ongoing. The people are coming together to say, what do we commonly understand to be supported living, supported housing, and can we agree a definition that encompasses it? Meanwhile, I think it is worth noting that within the departments and the agencies, the absence of a fixed definition hasn't arisen as a difficulty in working together.
But would you not accept that it does become a difficulty when we have evidence from the trusts talking about 18 facilities and then evidence from yourself talking about 414 facilities?
I think well, no, actually, I don't see that as being a difficulty. I mean, the trusts are reflecting those schemes which are likely to require intensive personal care services because the needs of the individuals are living in those. The broader definitions includes those housing schemes which, although providing a degree of support, do not require intensive support for people requiring personal care.
Well, let me put it a different way. In the absence of an agreed definition, there's a performance direction that has been issued by the department, which is a legal document.
That's a performance indicator that relates specifically to that part of the supported housing market that we're heavily involved in, which are those schemes where people require intensive personal care. And that's what we're looking, because, I mean, we would have no need or interest in issuing a performance indicator that related to those supported living situations where the support is not provided by
But sorry, I mean, Fionnuala just outlined in answer to Roy's question what has been measured, the 18 facilities. So
Under that performance indicator.
Well, what about the 414?
Well, can I think, Chair, it's about the way in which the care is provided. Okay, so within the 18 supported housing arrangements, whatever we're going to call them in the future, we make direct care provision. It's part of the design of the service that the Trust is providing the care hours into that facility. If you look at the sheltered accommodation, which is the old definition, any care that's required, and not everybody living in a full will require any care services, is provided in a different way, and that would be provided as a domiciliary care service if it is required into the individual living in fold or sheltered accommodation. So from our purposes in terms of what we're counting, and I know it's just about how we count things, is a clear difference in the way we provide the care, which leads us to separate out the 18 supported living arrangements under the performance indicator that we have from the department from any domiciliary care service we might provide into sheltered accommodation. That would be covered in our overall domiciliary care figures.
And indeed, there would be some people living in those sheltered schemes where the only support they're receiving will be from the on-site supervisor or warden. So we wouldn't be performance managing that at all. I mean, that's a service that we're not directly inputting to.
I think I would suggest if the committee can't have confidence in relation to the department's policy direction on the area, when before the review began it was working in a completely different definition of supported living than where we're at now. So, I mean, I'd suggest to you that we will come back to this, but it's certainly causing confusion. I think if we don't have an agreed definition across both departments, I would suggest, then what hope is there in terms of forecast and plan and strategic direction and the wider community out there in terms of all the issues that you raise around choice. But I want to move on to a different theme, and one of it is around awareness and the promotion of supported living, and I know Pam and Gordon had indicated that they wanted to lead on this.
Okay, thank you, Chair, and thank you for your presentation today. Obviously, as a committee, we've obtained evidence that there's a lack of awareness of the option of supported living for older people, both among older people themselves and the public at large. When departmental officials were questioned about the promotion aspect of supported living, they stated that people become aware of it once they come into the system, either via the housing executive for people already in social housing or through a social worker. And if people are having their health needs assessed, the department didn't seem to see the need to promote the concept of supported living more generally and the public at large. And I'm sure you'll agree that it really is much better for our older population to be prepared for those later years and to have the knowledge and awareness of any schemes that are or will be available to them for that time of life. So on the back of that, I have a few questions. The committee's also spoken to key stakeholders in the age sector, such as the Older People's Commissioner and the AGNI, and they told the committee that there was not a wide awareness of what supported living is among older people. And what I want to ask the department or departments is what you could do to change this. And I'll ask another question at the same time, based on the NI Federation of Housing Associations, who stated that there was a lack of awareness and suggested the creation of a supported living champion. So I would also like to ask your views on that suggestion as well.
Okay. I mean, I think the evidence that was presented the last time still holds in that for many people, the point at which they will want to know about supported living is the point at which they're being assessed for their needs. And certainly my expectation is that when that's happening with a social worker or indeed with a housing officer, all options will be discussed with that person, including supported living. But I am aware of the proposal from the Federation for a champion for supported living, and as I said in my opening statement, taking that into account and indeed the comments from our last appearance at the committee, we have now identified that as a proposal which we're seeking funding for. So we are currently in the process of trying to negotiate funding across the range of projects that I outlined in my opening statement, and one of those is to establish a champion for supported living who could take on that broader role of publicising the option and the benefits of supported living, both to community and to other stakeholders. Colleagues?
Yes, absolutely. And the committee might find useful, actually, there's some research that's been done by the Housing Executive in terms of two kind of cohorts. There was a piece of research done a couple of years ago by the University of Ulster, which focused on the housing needs and aspirations of the current older generation, or senior citizens, and that was very much focused on people were saying that they wanted to live in their own homes for as long as possible. We then commissioned, with Housing Executive colleagues, a piece that looked at the next generation, those who are currently in their 50s into their early 60s, the so-called baby boom generation, many more of whom are homeowners than the current generation of senior citizens. And what came out of that fairly small survey, it was only a sample of around 400, but that people didn't want to know about, they hadn't thought about their housing options for their older years. They weren't particularly interested in advice at this point, but as Sean said, they wanted advice closer to the point where they had to think about it, and that many more of them wanted to stay in their own homes for longer. So we can certainly send the committee, if it's helpful, the links to that research, but that sort of reaffirms some of the things that Sean said. But we agree, and the piece of work that our organisations led resulted in that proposal from the Federation of Housing Associations for Supported Living Champion, and we're working together now to try and secure the funding to make that happen.
Can I just add to that, sorry, but from a health and social care perspective, I mean, I believe that older people, that the population should be fully informed about the range of opportunities that there are as they move through different periods of their life and into old age. And as a consequence of that, there has been work going on within the Health and Social Care Trust to have more information. We've developed some DVDs. It sets out the range of services that people might expect to find if they are living in a particular area, and it includes supporting people. And some of our residents who live in supporting people are involved in that process as well.
It strikes me that, you know, just as we're all much more aware of pensions and actually taking more responsibility for ourselves in later years in life, that this is an issue that actually needs to come up earlier, and that awareness needs to be put out there. And we recently had a visit to the pavilions in Lisburn, and that was very much a case of it's for a limited market of people who would be providing for themselves, but still, it generates a lot of thought and discussion over actually, how is it best? How am I going to live out, the next number of years of my life? And I think it's actually a good thing to empower people with the information. And even give them ideas of how they could provide for themselves as well, especially given that the increased burden that there is on the health service in particular, and more so as to what it will be in the future with us having we're going to have such an increased number of elderly people in society. But I've a couple more questions here. The committee's been made aware that there are a number of vacancies in supported living facilities across the Trust. Is this a concern to the department?
Yes, I think it's a concern for both departments. I think that it needs to be kept in perspective. In any local scheme, there may be some vacancies, there may be some people on a waiting list. But if you step back and look at it regionally, the number of voids are not significant, nor are the numbers who are waiting, as far as I'm aware. But it is an issue, particularly in terms of retaining the confidence of housing associations in terms of future builds, because while the numbers might be small, and in terms of overall planning, the number of voids aren't very significant, for an individual housing association, for an individual scheme, the voids are significant, perhaps.
Yes, I think it reflects a number of points the committee have made around getting the education awareness out there. It relates to the proposals we're looking at in terms of how to look at the models, particularly outside of the larger urban areas, about the scale and size. But it's also reflecting the point I think Fanilla's made around giving people choices, that we need to be more smarter going forward to inform and give information to be able to senior citizens to make choices for their future. By and large, the 18 schemes that we recognise as supported living for older people are working well and have high level of occupancies. Some new schemes tend to take a while to get up to full occupancy, but they do for valid reasons. We have 1 or 2 services where, particularly in as well documented, I think you've had reference to it before in Fermanagh, where we do have a large level of unfilled places. And we are looking and active working with the Housing Association and the Western Trust to find a positive solution going forward. But we recognise we need to do more work in terms of the 3 pieces of proposals that we've set out to you in the briefing about what we want to do forward to learn from the lessons of those legacy schemes, what went wrong, what we can do better. Some of that is around information and education promotion of the service, but it's also about saying what's the right model when we get into the more remote areas or areas where there's a large mix of urban and rural communities and how you serve that population. So we recognise that and we need to do more. But in terms of those, majority of services are working well and working at high levels of occupancy. Don't cause us any concern. The 1 or 2 services that we have some challenges for, we're working with those agencies to find a solution. But it does impact on the confidence in the sector about getting the model right, understanding what that is going forward.
It seems to me, I know it seems to many of the members around, we've looked at some different accommodations, different supported living models, and been really impressed with them, and it's pretty astounding actually. There's not, big long waiting lists for people wanting to get into them. So I think that awareness is definitely a big issue, and I don't think people have choice if they're not aware. I don't think they have a full range of choice if they're not aware, and if they're waiting until they get to a crisis point in their life, that's limiting, their choices as well.
I absolutely think.
I think the point about raising awareness for people planning for their old age is a very well-made point, and that's one that we've taken on board from the committee and hopefully will address, and the proposal from the Federation would be part of the response to that. But I think for individual people who require a degree of care to meet their assessed need and are being assessed as having needs, when there are supported living schemes in their area which are available to them, they will be being made aware of those, but people are making different choices, and I think that's what often is leading to the situation where there's a void. The schemes have been built in the belief that there would be a demand, but people have made choices to have other kinds of ways of having their care needs met. And that's not a fixed thing, that's changing significantly. If you look at the lead-in time for building a scheme, it might be from the first point when the idea of having a scheme and people are looking at the assessment of need through to the front door being open will be a number of years. Now, over the past 5 years, for example, there have been a significant change in the range of services that would be available to people that might result in them choosing not to go into a supported living scheme. Reablement services, for example, 5 years ago were very limited, I think it would be fair to say, Fionnuala, whereas now we've got fairly significant reablement schemes in 5 trusts. Now, a number of the people who are going through those reablement schemes, were those schemes not there, might have opted to go into a supported living scheme, but now may be fit to, able to and want to stay in their own homes.
Okay, thank you. Well, just a final one from me. One theory as to why there are vacancies, and it could be the lack of the shared understanding between trusts and housing associations on what types of older people are suitable for supported living. So what is the department's view on who supported living is actually aimed at?
Well, Fionnuala will come in on this in a moment, but it is based on the individual, as I said at the very beginning, 2 factors. the assessment of need and how that need can be met, plus the choice that someone wants to exercise. Now, there are going to be situations of very high dependency where it isn't practical to provide for someone's needs in a supported living scheme, and a nursing home would be more appropriate. But I think that the boundaries as to where that difference exists have been pushed very significantly in recent years. Finola?
I mean, I think in a nutshell that people who are suitable are those who need care and need support. So some of it is housing-based support to be able to live in their own accommodation, and some of it is a care. I don't think we've ever made any secret of the fact that your easiest correlation, if you like, are those people who previously would have gone into residential care. So maybe 20 years ago, you had much younger people, much fitter people moving into residential care than we would have seen in the last five years. And it's that cohort of people who really can't live or choose not to live on their own for any longer and need a level of care and support. They don't need medical care, they don't need nursing care, they're not ill as such, and they can make a choice. They can make a choice that they want that companionship, and if you visited some of the facilities, you'll know that there's provision for communal space to have friendships and that kind of thing, but they don't, the key thing is they don't need medical or nursing care, because if they needed that, they would be in a nursing home.
Okay, well, if I could just maybe pick up on that, Finola, because when, you know, the trusts were before the committee, and they told us that supported living is a very specialised model of care which is only suitable for a very small minority of older people. And then in contrast, the housing associations told the committee that it's a model suitable for a significant proportion of older people. How does the department respond to that?
I could respond. I think because we're talking about two different things. When housing professionals talk about supported housing, we mean both those extra care schemes, like what we've called the frail elderly, or that unfortunate term, things like Cedar Court that I think you've seen, like Hemsworth Court, like Angara, like Seven Oaks, those schemes, and sheltered housing schemes, the traditional full schemes. So when housing professionals talk about, we mean both. So,
but sorry, we were being very specific in relation to this inquiry about the concept of supported living. We weren't talking about the overall package, and we were being very clear, and we knew exactly what we were requesting, and that's the response that we got back.
If you're talking about those people with very significant care needs, they are by definition a minority of the elderly population. I mean, the majority of older people are fit, well, independent and active, and a very significant number of older people are able to manage what limitations they have through their health or through disabilities with support. The people who we're considering as being suitable for the 18 schemes are not those people. They're people with significant care needs. And they would be a very small group in the overall over 65 population.
Okay, Gordon, I think on this issue you wanted to come on and
Yes,
talk
thanks,
the awareness.
Chair. Thanks very much, folks, for coming in this afternoon. Just on the points that has been made further, clarification, I think we would require, does the department believe it is possible that there are vacancies within such facilities because the trusts are under referring, saying that the models are only for those with complex needs? Is there a risk that that has happened?
I can't see any possible motivation for the trust to under-refer. I mean, when you're trying to respond to someone who has care needs and as a result requires assistance, it's in your interest to consider all the available resources that are there. I mean, there's no motivation for a trust to try and withhold information about a supported living scheme from someone who's presenting as needing one.
And I suppose we go back to the assessment. people get referred into social services, we undertake an assessment. We look at what the needs are and how those needs can be met. So it could be that there are some people where the family or the individual thinks, I might like to go into supported living, or I might like to stay at home, and the assessment of their care need indicate that that's not actually feasible, that they need an alternative type of care. I have no evidence to suggest that we're under-referring. I would go back to Sean's earlier point. I think a lot of it is around confidence in the style of the delivery of the service, and I think it's about choice, and people are making choices, and significantly people are making choices to stay at home if at all possible.
Is the cost an issue?
It shouldn't be a cost. All the care is provided by the trust. If people are on a housing benefit, then they are entitled to those benefits that help them with the costs. And certainly I'm aware, having visited some of the facilities and talked to the staff, that some individuals who would have alternatively gone to residential care are actually better off in supported living than they would have been in residential care because of their income status. So it shouldn't be a prohibitive factor.
And if you stay at home or you go into supported living, I mean, the care costs are met either way. There's no difference.
Was the cost not an issue for the trust then?
No, that's what I'm saying. The trust will meet the costs whether you're at home or in a supported living scheme.
I mean, if
In Northern Ireland, we don't means test domiciliary care, and we would include, if you're in a supported living situation, that's non-means tested. I mean, that differs from most of the rest of the UK, where you would be means tested, but here we don't.
No top-up fees then?
Top-up fees are a fee which is people will sometimes choose for an enhancement, which is not to meet a basic need, but is for an enhancement. I mean, so for example, you might want to have Sky Sports. Now, we don't pay for that. Sometimes people will pay a top-up fee to have a better than service.
But just to be clear, there's no top-up fee on the care element.
No, not on the care
Paid.
element, no.
There may be rental or maintenance charges that are applied in supporting people, but balancing that out with the cost of an alternative care in residential care, it shouldn't be prohibitive in terms of making this as a choice.
But would it not, sorry Gordon, just on this,
All right.
just, if you don't mind, you know, is there a cost analysis done there that I'm assuming that it would cost the trust more to facilitate somebody through a supported living programme, project, accommodation than it would in terms of at home?
No, not necessarily.
Not necessarily.
Depends
In terms
on
of
the level.
domiciliary care?
The domiciliary
I mean,
care.
they'll need the domiciliary care if they're at home.
But there's
They'll
no
need it in-
additional cost to accommodate? Okay.
Not
I
necessarily.
mean, actually, if you're in supported living, you have the additional support that's provided through the DSD Supported Living Fund.
Surely the buildings and the services are a cost,
Yes,
which are not a case when you're at home.
there are two sets of costs, and Brian can talk a bit more. There are the care costs, which are a matter for health, and there are then the costs of the rent, the service charge, and the housing support. And there are housing support services as well as care services. Housing support services would basically help people to live independently, so it will provide them with advice, support that we would take for granted, paying bills, those kind of things to support their tenancy. So if somebody's on housing benefit, those support costs will be paid. If the person's not on housing benefit, then there will be a cost to them of those services. So our services aren't necessarily free. They're free if you're on housing benefit or at a lower cost.
But either way, those costs don't fall to us in the health and social care sector.
Yeah, yeah. Okay, just a couple of other issues. Could you just clarify for my own interest how people are selected then for the accommodation? I take it to go onto the common selection scheme, the common list, come off the list. Do they?
There are two separate processes, and health colleagues can talk about the complex cases, those that go into the extra care, the 18 schemes. For the sheltered housing schemes, yes, those are allocated off the housing selection scheme, the common waiting list.
So they're done through the housing executive?
Yes, for
Yeah,
those
who
sheltered
manages it.
housing, yes.
Yeah, who manages it, yeah.
For around 400. For the other 18 then it's a different process.
So it goes on need then?
Yes.
Assessed on need?
Assessed on need.
To me, just I want to concentrate a bit on an area. Say an area like North Down where you're limited on stock of housing, very limited, then you're going to be in a position where your options are even less for this type of accommodation. So how are you going to address that? How are you going to address those needs and address the demands that are there and increasing, as my colleague has said, as people get older? What has been done to address that in areas where we have limited stock? Housing executive stock is, in some of the estates, is 25% is left, where the rest have been bought off. So of a mix of houses, so you have a loss of accommodation. So how are we addressing that issue?
Again, they're two separate issues.
Yeah.
Those 18, those extra care schemes, are the assessment of need is done by trusts. For general housing and sheltered housing, there's a system, top-down and a bottom-up system for assessing need. There's a demographic projection through a thing called the net stock model, which looks at projections for future need of general housing and sheltered. And then there's a bottom-up which looks at the waiting list and the needs in an area. And then there's an assessment done by the housing executive, which has statutory responsibility for that, and then that will inform a new build programme. So that's how it's done for general needs and sheltered. The extra care schemes would come through the board and the trust.
Can I maybe talk a little bit?
But is there not a tie-up between both? Are you not the main driver for housing, no matter what?
We're not the main driver for those which are.
There is an
based on
arrangement
care.
for
Yes,
us to
there's
work jointly
work
on the
jointly.
commissioning of those extra care or frail housing schemes.
But maybe just talk a little bit about how we're planning and how we're assessing need. We have developed what we call a GIS mapping system.
Yeah.
Okay. And it's not fully fledged yet. We are building it up. And I suppose remember that our planning cycle is somewhere between 3 and 5 years, and that's normally what we work on. So the map at the moment goes down to ward level.
Sorry?
It will go down to ward level across Northern Ireland. It will show us what services from a health and social care perspective are available in each ward. So at the minute we have residential nursing, we have the supported housing, we have sheltered accommodation. We can overlay community-based services on top of that, so we know what community-based services are being provided in the ward area. And our ambition, our next step, is to overlay the demographic information that we have on top of that. So we will be able to see where the demographic growth is going to be. We'll have to make some assumptions about shifts in demography, because sometimes people choose to live in different places. Members will know that at a point in time a lot of older people went to the North Coast in retirement. There's evidence in the future that the older people might congregate more in cities rather than go out into more rural areas. But we will overlay that onto our mapping system, so we will be able, based on some planning assumptions, to look at where the gaps are potentially moving forward. And I think that that's quite exciting. We haven't had the benefit of that kind of visual information before, and we'll be able to bring that forward. And in terms of the supported housing arrangement, we have joint arrangements with our housing colleagues, bring their information in terms of housing need together with our information about care need, to be able to plan for that in the future.
Okay, and just on the various trusts and the regional differences, what is the department doing to make sure that there isn't any real variance across the trusts?
Well, it wouldn't be an ambition of ours to make sure that there's no variance across trusts. The populations are going to be different in different areas, so there will be variations. I mean, the ambition is that we plan effectively for the needs in each trust area. Those are not going to be the same across trusts.
But how you allocate, and the points have been made earlier, about the voids and how it's important that that's done consistently.
I think it's important that we try and plan to make sure that there aren't voids. But if we were to try and plan that we had consistency, I would suspect we would have a far greater number of voids if we simply said we're going to have the same number of places in each trust area. But that would lead to...
But it's applying the policy, applying the guidelines consistently across the trust is what I'm getting at. What are you doing to ensure that that happens?
I have no evidence to say that the policy or guidelines aren't being applied consistently across the trusts.
Well, we'll see. It's early days. Okay, thanks, Chair.
Okay, thank you. Roy was on this awareness,
Yes,
yeah.
just earlier, Sean, you'd indicated in terms of the voids that you thought the reablement programme may have contributed to somewhere where the voids are. But I noticed that in your evidence to this committee on the 26th of February, you actually said that reablement had been rolled out in 3 of the 5 trusts and that plans were in place for the full rollout of the scheme. So I'm just curious.
I think we now have schemes operating in all 5
Yes, but I'm just trying to ascertain what degree reablement may have contributed to the voids. And can you tell us when reablement, or come back to us, when reablement was fully run out to all of each trust? And in particular, when was reablement operating in the Enniskillen areas where there were a significant number of voids?
I don't think reablement is probably a significant feature in the Enniskillen example. And I was saying reablement is an example as to how the picture can change. I don't think that I would attribute any particular voids today to the existence of a reablement service. I mean, I'm sure there are circumstances where that's true, but I couldn't identify those. And what I'm saying is that services are developing all the time, and that is having an impact on the choices people make. And some of these are very long lead-in times. Some of these are new services that are changing currently.
But you did say earlier that reablement was a feature of it?
I think reablement is a feature and will become a more significant feature. I think generally domiciliary care and the growth of domiciliary care over the past number of years has been a more significant feature. Another feature that we haven't discussed so far that probably is starting to affect the choices people make are that since 1997 in Northern Ireland, all social housing has been built to a standard which is, colleagues will correct me, I think it's called lifetime standard. And the idea is that you build a house that can easily be adapted to the different needs, so that the house that you live in and bring your children up in and the house that you live in through your middle years can also be adapted to be the house that you grow old in and may end your days in. Now, since 1997, all social housing in Northern Ireland has been built to that standard. I would imagine as people living in those homes have been approaching their old age, a growing number of people have been able to stay in those houses, and that probably has contributed to why some people have chosen not to go into supported
I think,
housing.
Sean, I think we're mindful of that and aware of that, but that's not what we're looking at in terms of the supported living issue.
I think, Madam Chair, the point is that it's probably not helpful to look at supported living in isolation. Supported living is one way that we can respond to the wishes, desires and needs of older people for their accommodation and care needs.
Yep.
And
But that's the remit of this inquiry.
And what I'm saying is that when we provide that care, we do it in the context of a range of different services, and people make choices between them.
Okay. Roy, are you finished on that point? I just, before we move off that awareness issue, because I do think it's important to make this point, the Belfast Trust, and this is the issue of cost that I've raised, and you're both indicating that there's no additional cost. Belfast Trust said this model of care is very specialised, it is very expensive on the capital and revenue side. It needs to be targeted at people who most need and could most benefit from the model. A few other comments there. It said, so from the department and the trust's point of view, it is very targeted at those who would most benefit from it because it is expensive for the state.
The capital cost is expensive, but the care package is the care package, whether you stay at home or you're in one of these schemes.
I mean, I think we've given you a breakdown of the costs of each scheme.
But sorry, sorry, Finola, John, we were trying to tease out there a few minutes ago about the cost for a trust in terms of a supported living model. Mm-hmm. The response we got back, Sean, was that there is no additional cost. That's contrary to the comments we have here from the Belfast Trust. So who who's right? What's accurate?
Only
Perhaps-
could
perhaps
be referring
maybe-
to resettlement.
Well, possibly I misinterpreted the question, and I hope I'm not misleading the committee. Certainly I was very focused on the cost to the individual, because I thought part of the question was the cost to the individual.
Sorry, we asked, sorry, Vanilla,
Yeah,
with
no,
respect, we asked specifically about the trust.
I probably misinterpreted it. I'm claiming that. There certainly is a cost to the trust, and some of the Belfast provision is for people with dementia, which necessarily will have a higher cost than some of the other schemes, because the annual care costs are quite varied. So it depends on the layout of the building, the nature of the residents, so the people who are going to live there, etc. If you're asking me, is it additional above and beyond what other service might be provided? Is that what you're asking? So there has to be an additional cost. It's a new facility. So
There is an additional
therefore,
cost.
we have to put some money in to provide the care. And we're increasingly providing additional amounts of care to individuals every year. So the cost to health and
So there is
social
an
care
But that
trust
cost
is
is going to
increasing
be,
generally.
I mean, there's going to be a cost to caring for that person wherever they are.
But that cost, there's an additional cost in terms of the trust.
Yes, there is.
Would that impact in
On the
terms of...
decisions to place people? I don't believe so. I don't believe so, because in setting up these facilities, we have a business case. We develop the business case aligning the supporting people income that's available for the facility and the care income that's available. So there's a commitment to that care income for the number of places in that facility. If there are vacancies in that facility, you could say that that's actually costing us money, because we're not getting the full value of the care costs that we are putting into it. So I think it would be the reverse. We would be encouraging people to move in, because that way the unit costs for the facility are lower. I don't believe that it's a reason why Trust would not be referring people or admitting people into sheltered accommodation.
Okay. Moving on, one of the other themes was the issue about housing associations being cautious about building any new supported living, and Mickey and Roy had indicated that they wanted to lead in this.
Thanks, Chair. Thanks for the presentation. I suppose the first comment I'd make is encouraging, almost unique, to see people from DSD and Health actually sitting together giving evidence. It certainly doesn't happen often enough, and as someone who sits in both committees, these are the type of overarching issues that should be addressed by both sets of officials. And just one thing you said, Sean, about lifelong housing being built since 1998. I think I'd take issue with you there, because in my own constituency, about 4 years ago, Trinity Housing Association built 5 houses, which were lifelong, and they were hailed as wonderful, and they are. They're very well built houses. But I wouldn't accept that housing associations are doing that on a regular basis, because the reality of all this, and it is a wider issue, and I know, Stephen, you're very familiar with the whole social housing issue, and we have a public housing body that doesn't build public housing, relying, because of government policy about borrowing, we rely on housing associations, and this is the issue. In the Enniskillen example, the Fold have lost something in the region of £1 million in revenue. That's being replicated in places like Glasgow because of the bedroom tax, huge swathes of houses that people won't move into. So housing associations will be going out of business. So it can be a wider issue. The difficulty, and Enniskillen may be a different example, because I know in my own constituency, in Uri, for instance, people are queuing to get into the Fold. You know, so you don't have that void issue. You know, somebody is flats vacated or whatever, then people are moving in on referral from the trust. So it happened. Maybe it's just that area. But obviously the issue has been made about making people more aware. The difficulty you have, Fold have said they're not going to invest in new more bills for this kind of facility. So I think the difficulty then is if housing associations aren't going to build the facility, it doesn't matter what you put into them, because it won't be there. So that needs to be addressed, and needs to be addressed urgently, because you know we can have all the best plans in the world of what is available, but if the actual physical housing isn't there, and this is going to become increasingly a problem, because housing associations, we have 30 odd here in a relatively small area, all kind of competition in some ways, some quite large ones, some smaller ones, but there is that difficulty. In terms of houses being built to a standard, they are a decent home standard, and if you look at the Savile report in 2009, we had some of the best housing in Western Europe, but it's not anymore because planned maintenance doesn't happen. So there's all sorts of issues around that, and housing associations need to keep the houses up to a particular standard. So, you know, what happens if they say, well, we're not like folk, we're not going to build anymore because of the voids, and it's actually costing them money? Because they rely on, obviously, the housing benefit of the rental to service their loans.
If I perhaps deal with the lifetime homes issue first, all housing associations have to build to what's called, as you know, the Housing Association Guide. The Housing Association Guide has in it a lifetime home standard, so, and there's a multiplier, there's an incentive for that. So all housing that they build is built to lifetime homes. During the downturn, housing associations did buy some properties off the shelf and took opportunities, and those wouldn't necessarily be built to lifetime homes. But if I could just give you an example, and I think this exemplifies it, because of that, the adaptation costs in housing association properties for older people that want to age in place are significantly lower than those for executive properties. Around £11 million a year is spent on adaptations in executive properties. Around £1 million a year is spent on adaptations in housing association properties to support people to age in place. So that forward thinking that we've done through putting lifetime home standard into the design guide allows people to age in place, and that's really positive. On the point on risk, we jointly managed, on behalf of the ministers, the session that Sean referred to with housing associations and trusts back in February. The two issues that housing associations came to us on was firstly, because of the specialist nature of some of these schemes, it takes quite a long time to fill the places. Hemsworth Court in Belfast is a good example. The Belfast Trust is taking about 18 months to fill the places. While they're being filled, the money from the trust follows the person. If there's not a person there, there's no money. So the ministers have asked our colleagues to look at a risk-sharing arrangement, and that's certainly something I think they're doing, and they can colleagues in health can update you more on that. So there is a loss being sustained by housing associations in that period where full occupancy is being achieved. The Enniskillen example is a particularly challenging one, and I think what that says to us, and one of the things that we want to look at in the piece of research that Sean referred to, is that model of very specialised housing, in order to make these schemes stack up, there has to be a certain number of places. Small schemes with specialist services don't stack up economically, they don't work financially. So a very specialised housing model, it's questionable whether it's going to work everywhere in Northern Ireland. In some places it will work, in other places it won't. And so two of the pieces of work that we want to do is firstly look at the model and look at what will work where. And there'll be a lot of financial stress testing needed, and hopefully that will help to give housing associations the confidence that they need to re-engage with this work. And the second is to look specifically at Angara and look at Hemsworth Court as well, and look at what happened, what went well, what didn't go well, and what we can do to fix it. So we're very aware of the problem. Some associations are continuing to develop these schemes, but more are becoming more cautious because there is a considerable amount of risk. So there does need to be some sort of element of risk sharing, and that's something that we're looking at.
Could I, sorry, just finish that? If you look at going back a number of years where old persons' dwellings were built, because the executive at that time were actually building houses and got a subsidy to build them. And then as time went on, they then became single persons' dwellings, so they're 1 or 2 bedroom bungalows. Initially they weren't selling them because they were being retained, and then you sort of the supported living or supported housing has kind of taken over in a sense. in the Enniskillen example, or indeed if there are voids, because you're talking about 18 months and quite a period, has there been any rethink in terms of those facilities being used for provision of social housing? Because it seems to me you have obviously very specialised facilities, but they're not being used. The housing associations, and you have mentioned about maybe sharing the risk factor with them, that if people were living in them, irrespective of their health and disability and that, at least there would be revenue being generated through housing benefit or rent. I'm just wondering, is that, because how long can you leave them sitting there, and
My understanding is that Western Trust are working with the Housing Association to look at how those void units can be
Certainly in
used.
terms of Nangara, and I have been involved with meetings with Fold as well. I'm aware that we've taken quite a lot of measures to look at the scope of extending what the facilities could
Just
be
change
used
the
for.
criteria, in a
Change
sense.
some of the criteria. There is a particular need that had been highlighted, say, for people with physical disability, and looking at would the chalets or the flats lend themselves to that. I think, if I'm being honest, there is a lesson to be learned in the design because it's on site with a residential care home. And we need to think about that in the future as well. We need to get the design flexible and right so that we can accommodate a range of need if and when it happens, because one of the things that we're saying to you is, people make choices, so there is a level of unpredictability about how quickly these facilities might fill up. But certainly the point's well made, and we have been in discussions with Fold and with Western Trust on that.
Thank you.
And as a result of some of that, just to finish off, I think the occupancy had increased, but still there are a number of voids that we need to consider.
Is it on?
Yeah, just on that, I've done a bit of research. I understand half of those units were for dementia patients, is that right?
In the residential sector?
Yeah,
Yes,
yeah.
that's right.
Is that not an issue? I take it the department tasked the Housing Association, who had to tender for the work, to compete for it. They were tasked by the department to build these units, is that correct?
Well, the department doesn't directly, it's the
No,
the commissioning process.
We have a joint arrangement with the Housing Executive and the Health and Social Care Family, if you like, Trust and Board. And there is a supporting people commissioning body, which is chaired by the Housing Executive. And the purpose of that is to identify the need and then commission those kinds of developments. Now, I suppose, I'm not sure if Brian would agree, but we've got more sophisticated as the years have gone on about the needs assessment and the commissioning arrangements. I think there is a particular, when I look at the voids and the vacancies, Nangara obviously stands out as a particular issue.
The housing associations obviously now are shying away from such projects because of the mistake that has been made here, really in the assessment of need. Is that where it just went wrong? They said, when we went back earlier, you clarified that people are allocated on need, if the allocations are made on need.
Yes, they are.
And you build on demand where there's a demand.
Yes.
So where was the mistake made? Did we get it wrong? Did you get it wrong on demand? Was it demand? The assessment, was that made wrong by health and transferred to DSD?
Well, I think at a point in time, we felt our assessment of need was accurate. Things have happened in that period of time that mean that people have different options. You could say that we got it.
What period of time are we talking about? 3 years?
No, Nangara has been open since.
And Nangara's been open for coming close to 4 years.
4 years.
But if you take the point, I think Sean made, the planning process, the planning commission process probably started 2 to 3 years before that to get it on site. And we do work very closely with the Health and Social Care Family across the 5 trusts. There are lessons to be learned from the Nangara experience. We know that the demographics would tell us that in from an area, the growth in number of older people and also the growth in terms of people with dementia. So the planning assumptions and the planning guides was that this would need and demand would follow. We are, to take the point from a previous committee member, we are working very hard, and there's a meeting on Tuesday next with the Western Trust to try and find a solution because there's good quality housing sitting there empty, to take your point. So that's something that, from a housing professional's point of view, is something that we find easy to take. But throughout the process, we have continued to engage with the Trust because at the same time, the committee knows that in terms of the demographics and the stats, there is an issue to plan for more and to develop more. I think some of the lessons are around the promotion work and understanding, which the committee have also made a number of times. And we are looking at alternative uses of the accommodation to address those issues, to give confidence back to the sector. I think Fold's experience has been particular. It is a potential outlier, but we do know that it has an impact on the confidence of the rest of the sector. But you'll have seen in your briefing that there are still 7 schemes being planned, new service just opening, taking people in Newton Arts through this month, plans to develop a service in your own constituency in Bangor. So the associations are on board, and you heard from the chair of the Chief Executive of the Federation, who's saying that this is what the sector wants to do. They've talked openly to us as a sector about what they need from us to reassure them of the future of these services, and we are trying our best to respond to address that, to reassure them, because I think the committee have been to Cedar Court, and from a housing side and from a housing perspective, we're very proud of the quality of that work and what you've seen there. We need to make sure that we see those services developed elsewhere. So we're doing a lot of work with our partner organisations. I think there are lessons, to be honest, that we need to learn in terms of the needs assessment and planning. Part of it, I also think, reflects of talking to other people about what they want, and a number of the committee members have made that point today. And we need to be smarter at asking other people what their preferences are going forward, because they will have choices, and they will want to make choices. The generation of people, older people going forward, will want to make informed choices about whether they stay at home, whether they move, what services they come to see them. So we recognise that, and we're doing, and as Stephen has pointed out, the 3 projects we've put forward there in the briefing all impact on terms of dealing with the design, making sure the project's sustainable, also providing reassurance to the sector. Even on Hemsworth, and that has been an interesting project just off the Shankill Road. It's 35 self-contained units. Again, it's another very worthy project, and the association are looking to make an application to a design award competition. We're sitting there with 35 units, good quality accommodation, very high quality accommodation. As of today, there are 24 tenancies in place. A further 7 people are being assessed. And there is a balance on the health side about working with the individuals and their family and their carers about making that transition from where they are now into Hemsworth Court a planned and appropriate one. So we've got to be conscious of working with the individual. But there are 7 further people in assessment. And there are lessons there about how we make sure those assessment processes are sensitive to the individual needs of the family and the individual, but are working through. So the Trust and ourselves are confident that that project in Hemsworth will be fully occupied by September, October this year. From a housing association point, that's probably a bit too long. It opened last July, so we're looking at what we can do to reassure the associations on those issues.
Okay. Just finally, is there maybe a lesson that we learned about the mixed use of the dementia with the supported? Is that possibly a lesson that needs to be learned?
I think how we adapt the accommodation based on the fact that there's a residential unit and there is supported living on the same site is an issue. And I suppose, Brian would agree, I think if we'd built in a bit more flexibility around the design, it might have meant that there was more take-up earlier. But as I say, we have learned those lessons and taking those forward into our planning processes.
Thanks very much. Thanks, Chair.
Roy.
If I picked it up correctly earlier, someone said that the alignment of the business case from the housing side and the health side, and that there would be a commitment to care income. So, can you just explain the commissioning process for such a new development of what we know as supportive housing?
Yeah. Do you want to start, Brian? Could you take the lead, really?
And the supporting people started in 2003, we talked to our colleagues about what the right kind of commissioning structure is. So there's a regional commissioning body that the Director of Regional Services and the Housing Executive chairs, and it's made up of representatives from 5 local supporting people partnership groups based on trust boundaries. At those structures, the Trust identified their need for supported housing in the future from across a number of programmes, including older people and dementia. If there's a need identified, there's a business case produced at a local level that comes through the commissioning process, and that business case is to bring forward and align both the capital and the revenue from the supporting people side, and also from the care side in terms of the need and the type of services. That translates what we do on the housing side is, once we get to a certain point, bring in the housing association nominate names so they can forward the development process to find a site suitable for development. And through that lifetime of the business case, we engage with our colleagues and trusts and with the Housing Association and other agencies around the project planning of each service. And in that structure there, we have an opportunity to learn the lessons and to reflect on the lessons of what's worked well elsewhere. We're looking at restructuring or reforming some of the commission process to have a kind of more regional structure where we bring the 5 trusts and the board and ourselves together on a more regular basis to look at lessons learned and going forward. But the process is a bottom-up one informed by local commission decisions by the trust, who then bring forward a business case for the Supporting People programme, where we look to align both the capital and revenue, capital from the DSD to fund the building, and from the revenue side from SP and the care side, so that all bits of the jigsaw and all bits of the funding are in place. And by doing that and bringing the Housing Association involved early, I think that's another lesson from us as well. We can do that, gives added confidence to the sector that we're keen on that working, and there are things that we could do better on that. The business case critically is to provide a reassurance that there's a need and that the various bits of the funding pot are together to make these schemes happen. It can take maybe too long because the site search and the planning and all that can, as you probably know from your own experiences, can be a lengthy process.
Having followed the Green Island House development, which is still to commence on ground after 4 or 5 years, but going through the planning process, my understanding was the trust would okay the business case as to what they think is required in the area, and it's actually, as I understand it, the business case is to serve the Carrickfergus and Newton Abbey, quite a wide geographical area. But I'm just curious as to what care commitment in terms of care income there is if the numbers do not hit what the trusts say is needed in the area. So what care commitment is made by the trust that what they say is needed actually turns out? What commitment is made?
Well, in terms of the business case, it would identify what allocation of funding the trust would be making into that facility to cover the care costs. So based on the number of people and an assumption, aligning it with the Supporting People revenue that might be available. So it's all worked out in terms of what income has to be set aside as a commitment from the trust in relation to the building, assuming full occupancy. I think that our colleagues in DSD and Housing Executive are saying to you that where there is not full occupancy, then that becomes problematic for the trust because they're having to pay for the person somewhere else. The money follows the person in there.
But if that was the case in Enniskillen,
yes,
the Housing Executive wouldn't be the Housing Trust wouldn't be losing money.
Well,
is the Health Trust paying for these vacancies?
No, they're not, and they're not currently, and that's the point that was being made about coming to a position where there's more risk sharing between the Housing Association.
So have you changed your policy then that you will commit to paying for vacancies from the caring side?
Discussion.
It's currently under discussion, but the money that, if we were to pay for those voids, that's money that would otherwise be paying for the care of older people. So we're obviously reluctant to make sure, well, we're keen to make sure that when we spend money on the care of older people, it is actually delivering care for older people as opposed to paying for a void.
But has it been a policy change from the trust that's pointing people to their care packages in their homes rather than care packages within another establishment?
No. If I understand your question correctly, no.
Well, I seem to sort of pick up a comment that some personnel may have changed in the planning process, and that may be a contributory factor.
I'm not aware of that, but I'd take the comment.
But final point then, in terms of the risks of this, I mean, I was dealing with some constituents a couple of weeks ago, and they were rented housing accommodation, and they were explaining that they only could get a 1-year tenancy agreement. That's all that was an offer from various landlords. If these properties are sitting vacant, can you not at least allow a temporary tenancy arrangement to be utilised so that income can be generated for the housing trust rather than them suffering the expenditure with no income whatsoever?
You mean to be used for general housing purposes?
For purely temporary basis?
I mean, I think if it's a highly specialised scheme, we would need, as Fionnuala mentioned earlier, we'd need advice really from the health and social care professionals around that, because putting people with different needs together in a facility with a lot of common spaces may be problematic. On sheltered housing, certainly, while allocations are done through the housing selection scheme, if there are voids, there are opportunities there for housing associations to advertise those out with the selection scheme if there are longer term voids. On those more specialist schemes, it's a bit more difficult, and that really needs a discussion between us.
But frequently there are frail elderly who are awaiting perhaps a bungalow accommodation or something like that, and have the trusts and the housing side considered short-term temporary tenancies so that there would be mutual benefit for tenants who are in unsuitable accommodation and for the fold housing who are having to suffer loss because there's no tenant whatsoever in their brand new housing? Have you considered flexibility of the temporary arrangement?
I think your point's well made, and I think we need to be mindful of the particular experience of fold in Enniskillen, as generally most of the other fold schemes are sitting at over 95% occupancy. It's a very particular set of issues around a particular project in Enniskillen. What I would say is that we're exploring all options, and a number of the committee members have made it to find a solution to get the housing let in Enniskillen. We're mindful of a short-term let. Maybe asking someone to move in for 6 months is not necessarily always a good thing for the longer term for other people to move a number of times. But we are doing some hard work to try and resolve and recover the position for Fold and the Trust, because it's in none of our interests, the Board or the Western Trust, the Housing Executive or Fold, to be sitting with a property that doesn't work in Enniskillen. So we are looking at that. Whether there's short-term options, I'm not too sure of. I think we're looking at making a better use of the project going forward.
Well, I think it's fair to say that we haven't done it as yet,
Yep.
but it's certainly an issue we can take away and look.
I'm just conscious that if this was a private sector operation, you wouldn't be sitting in the long term with your operation sitting vacant. That would not happen. Decisions would have to be made quickly.
Although, just to refer committee members to the paper, I think that you'll see that many of our supported housing arrangements have full or 99% occupancy. So it's just to draw your attention to the fact we are talking about 2 of the 18 facilities. By and large, the others are well used, and there aren't significant occupancy problems.
Thank you.
Okay, thank you. Just moving on to the issue of long-term planning. And I suppose bluntly, asking the question, Sean, of the department, is the department taking a strategic approach to the need for supported living?
I think that the department is taking a strategic approach in relation to the care of older people by identifying a general shift in how we provide services. And that is in response to what older people have told us whenever they've been consulted. That is primarily that they want to live in their own homes. And they want to remain as independent as possible. And that's the strategic direction that we've set. I think there's a difference between setting a strategic direction and a detailed plan as to how many units of what particular kind of accommodation you'll deliver in any specific year. And that has to be a much more short-term activity. And I think Fionnuala has described the current planning cycle as following a 3 to 5 year cycle, and the planning arrangements for that. I think also the indications that we've had around the discussion we've had about voids in particular schemes, but also the fact that we don't generally have significant waiting lists or voids around supported housing as a whole, would suggest that working to a 3 to 5 year cycle is probably working quite effectively. And I think there are significant risks if we were to try and extend a planning frame linked to specific units much beyond that.
So what you're telling me is that you have a strategic approach to general care for the elderly, but you do not have a strategic approach to supported living.
No, I didn't say that. I said that we have a strategic approach to the care of the elderly, which includes a range of options that we recognise need to be developed, including supported living. I think that there is a difference between strategically identifying the direction you need to go and then making operational plans for how you deliver on that direction. And the timeframes are different. I think strategically, we're looking 20 years hence, saying that we need to have a shift in direction. I think operationally, we're looking at 3 to 5 years hence.
So if we have the general strategic approach and supported living is within that general care of the elderly, have we done work within that to forecast how many older people in the north would be suitable for supported living or would actually want or need?
And that's the work that's done on a 3 to 5 year framework. And, I mean, Fionnuala took you through how that work is done currently and plans to improve it currently, but that's at a 3 to 5 year framework. I don't think it's very wise to try and make those kinds of projections beyond that kind of time frame. And there have been a number of experiences in sectors where, for example, people have tried to do very long-term planning based on demographics, and unfortunately it's gone badly. I remember being involved in a planning exercise about 10-12 years ago, looking at the future healthcare needs of the population in Northern Ireland, and at that stage we were anticipating a decline based on demographic projections of children. Turned out to be completely wrong. Things happened, and this has happened across the UK, that actual demographic projections turned out to be very, very misleading. And the further you go out, the greater risk there is. I mean, in the case of children, we had significant inward migration, and that population of inward migrants turned out to be far more fertile than the regular population, and so we've got significant pressure on maternity and birth services. Now, if we'd planned purely on demographic projections, you would have committed resources in a way that wouldn't have actually reflected the change in the population.
But also, Sean, we've just heard a few minutes ago about a GIS system that's going to be brought in terms of health and social care, which is going to take it down by ward.
Yes. But the time frame that will operate on is not 10, 15 years to the future.
You see, whilst I would accept that forecasting in terms of population and even, you know, per location may not be 100% foolproof. We know the statistics in terms of the ageing population. We know that there's going to be an additional 344,000 by 2020 over 65. We know that. So therefore, you know, the key question, and a lot of the evidence that the committee has heard to date, is that there doesn't seem to be that strategic approach to not only the operational side of it, but setting the policy. So what I'm hearing from you today is, as it stands, even in terms of that forecast, if we've supported living as a concept within general care of the elderly, you haven't as a department even forecast within that calculation that you have around the need that would exist for supported living.
I think that while people talk often about the demographic time bomb, you need to be cautious, and to continue the analogy, it's a bomb that goes off very slowly. If you actually look at the changes in the population year on year, changes are not significant. And given the time frame to plan for supported housing, your frame for making adjustments to meeting demand are better done on a 3 to 5 year basis. If we're looking at the population of older people, and I'm not quite sure I recognise the figure that you quoted there about the increase in older people, I would have thought...
Well, I mean, it's figures that have been given directly from Truss, from AGNI, from the Older Persons Commissioner, you know, that have been identified. And I hope that you're not saying now that we don't have an ageing infrastructure,
Oh, no,
we don't have an
definitely
ageing
have
population.
An ageing population, but the expectancy that I'm looking at is that over the next 50 years, the population over 65 will increase from 244,000 to just under 500,000, and that's not the figure that I think that you quoted.
Well, look, there's a sizable,
yes,
there's a sizable shift in over 65, yes. And that's a fact. So what I'm trying to ask here is, what is the strategic approach in terms of setting policy that the department is using to address that need?
And I think the approach is to plan on a 3 to 5 year cycle to respond to that need. I think if we tried to plan on a much longer basis, the risks would be of greatly exaggerating the kinds of problems that we have currently a very small reflection of the void situation, for example.
Except 3 to 5 year cycle. So has that strategic planning started?
Yes, that is an ongoing
Right.
rolling process.
And can we have sight of it at some point?
I mean, you do have sight of it in that the current plan is for 7 new schemes to come online, and that's on a base of rolling planning for demand. I mean, the assessment is done on an ongoing basis. Schemes are identified as being possibilities. Business cases are prepared. They're taken forward, and that's being done on a rolling basis.
But, yeah, again, if we're talking about 7 schemes, in the overall calculation of whatever the figures are by 2020, which we accept is a huge increase in our over 65s, is even 7 schemes? That seems very little.
Well, of course, there'll be other things that have to be developed to respond to the overall population increase. So it's not just relying on supported living. I think what I described earlier was a progression from our planning arrangements around supporting people, which was very local, to actually looking at the need for supporting people much more broadly. I mean, I'm just describing a mapping system. It's just a visual representation of what's available, what the population is in a locality, what the population growth might be, so that we can then make some assumptions about the percentage of the population that might need more domiciliary care, more supported housing, more nursing home or less nursing home beds.
To put the number in context, I mean, over the past 10 years, the elderly population, i.e. those between 60 and 84, has risen by 20%, while those over 85 has risen by 38%. And in that period of time, we have developed the supported living schemes that we've developed. We've no evidence to suggest that we've got that significantly wrong, with the exception of 1 or 2 schemes where there are voids, and I don't think that's probably down to us miscalculating the population projection. We seem to be getting it right. So when you say 7 doesn't sound very much, as I say, based on the increases that we've had in the past 10 years, the schemes have responded to the demand.
Okay, so I'm going to go back to the point about the forecasting, because I know Fergal wants in on this as well. We're saying, what you're saying to me is that it's a 3 to 5 year cycle in terms of strategic planning. And I think that that's accepted. Did that start when the whole concept of transforming your care was initiated?
Basically, in formulating the comprehensive spending review bid, the comprehensive spending review has mirrored the assembly period. In formulating the bid, officials from my department and from the Department of Health worked jointly together with the Housing Executive and with the board in formulating that bid. The numbers that you have in the briefing were our joint assessment of what was needed, and a bid went forward for funding, for capital and revenue funding on both sides on that basis, and we will do the same again for the next comprehensive spending review period, 2016 on.
Appreciate that, Stephen. But the point I'm asking, I suppose, specifically, John, is that transforming your care, a major plank of transforming your care was the shift left, obviously, the 83 million shift, and a big focus on reablement. And a recognition about an ageing population. So did that strategic planning in the context of supported living align itself with the origins of TYC? Because CSR is before that.
The planning process has been evolving since the introduction of supporting people, so it actually predates TYC significantly.
But there isn't a piece that would, there isn't a planning piece that would be attached to TYC that would say, here's where we will be in X amount of years and here's the need.
But we have a planning process. I mean, just because TYC has identified overall the policy direction, which is, as you said, the shift left, if we have a planning process within that that is fit for purpose to deliver TYC, why would we change it?
Well, we're not sure that there's a planning process there, but
Maybe,
Michael, sorry.
Chair,
Yeah.
sorry. Maybe it'd help him. I think you're looking for something kind of solid about the planning process and modelling for the provision of services. And I think during Sean's introduction, he talked about 3 particular projects that we're getting underway at the minute. But one of them is to look at alternative models to the way that we work, see if there are shortcomings in the way that we work, and if we can learn lessons. So that's what we meant by modelling in that framework. So, I mean, we're not being complacent to think about the 3 to 5 years, but given the difficulties that you've acknowledged in long-term planning with demographics, number one, we think that what we have isn't perfect but works. But number two, we're not too complacent that we wouldn't look at alternative models, and I think that's what we're looking to do in conjunction with our colleagues over the next
So
months.
we're only starting to look at those alternative modelling processes now?
No, I think it would be fair to say that the model of joint commissioning has been evolving continuously.
I think
We have some specific proposals that we shared with you today.
Sorry for interrupting. Sean. I think it would be fair. Sorry.
No, go ahead, and then I'm going to bring Fergal in. Yeah.
I think it would be fair to say that it's a bit of chicken and egg, to be perfectly honest. I think that TYC was informed of the joint work that we had been doing around supporting people. And I think also TYC then is driving us to do more modelling and more predictions, if you like, over the next 3 to 5 year period. So it's a bit of chicken and egg. TYC was informed by some of the work that had already happened and sets out a vision and a direction that needs to be supported by some further work that needs to
But it's almost 3 years into the process. But however, Fergal indicated.
You may call it chicken and egg, but it sounds to me, on the basis of what I'm hearing today, it's make it up as you go along. In terms of 155 places, where are the figures that show 155 is what's needed? What figures have you predicted? How far short of 155 are you, or how beyond? What's the figure? Where's the work in terms of projections?
That's a board and trust projection. So those figures come from the boards and the board and the trusts.
But where are they?
Well, it would have been done in the context of that 3-year planning. So to inform the plan that we already have, which is 18 already developed and 7 now in the plan for further development.
Yes, but how near is that to your projections for what's needed? Where are the projections?
They would have been done at local trust level.
And who's collates those?
The trusts.
And
In terms of
have you got
assessment, the
them
needs are
collated here?
quite localised.
Yeah, have you got them collated here?
Well, the collation is the 155.
No, the 155 is what you're building. How is that consistent with your projections? Is it consistent with your projections?
We build with a view to what we believe will be filled.
And therefore, how does that give people the choice if they're filled?
There is a degree of obviously churn in each of the facilities, which that's a projection based on what we believe people will choose. These are not built all to individual people.
But what I'm saying is, can you point to the body of work that's done? You're talking about another research project here. Was there another research project consistent with that one that you're planning now? Where is that body of work?
Would have been done at local level by trusts, and it would have amounted to a definition of the 155, the 18 and the 7 that are now projected, and that would be the extent to that modelling that would have been done thus far.
Right. I hate to bounce this one on you because it's just literally out, but in terms of because all of this is going towards homes and people living in their own homes, but the Older People's Commissioner today is saying that 70% of older carers are not receiving the carers assessment. Do you have anything to say about that?
I would really like to have the chance to look at the statements. I mean, I think that we do have a recognition that older people who are entitled to a care assessment are not always taking it up. We have a target
Yes, it's a
to
target
increase.
within the department to increase the number of assessments, carers assessments out there by, I think it's 10%. I'd have to check that, go back into figures, but that's the strategic direction of travel as far as carers assessments are concerned, and be happy to give you the detail of that.
Yeah, and I think it's just wise to remind ourselves of the second objective of this review, which is about it's about assessing the capacity of supported living options to meet the policy objective of transforming your care in terms of reducing the need for residential home places. And the older Commissioner's evidence just before was that she couldn't find any departmental planning or modelling data for the future demand for supported living. So
the modelling isn't done at the department. The modelling is an aggregate of local work which gives us a regional picture in relation to supported housing.
So who takes the lead here?
There is a joint commissioning arrangement between housing and health who lead on modelling for the demand for supported housing.
Yeah, and I think some assumptions are made, and refer back to what you said earlier on. The majority of older people are fit and well and active, and others are able to deal, I'm not exactly quoting you, with little help. So is that the working assumption that you're going on? That most people are fit and well and active, because TYC is based on the premise that older people are getting older and there's a greater demand for hospital and other services. Which is it to be?
Both statements are correct. The older population is expanding, and indeed within the older population people are remaining active to an older age, but the old are also expanding, and that group are much more likely to require significant levels of service. So, I mean, if you go back a number of years ago, people were entering into residential care and nursing home care at a significantly younger age. People now maintain their independence to a much older age, but the number of people who are in the old category are also growing, both in actual terms and as a proportion.
I hear what you're saying about the 3 to 5 year plan, but isn't there a need for further interrogation, given that decisions made today, and you've talked about the failings. I think you said that the assessment of need was inaccurate in the past. Isn't there a need then for good work to be done in terms of trying to establish beyond a 3 and 5? Because you are in danger of making it up as you go along, or falling shy of what would be reasonable expectations for the older people population.
I suppose just to clarify, I think we were talking about possibly Nangar at the time in terms of the assessment of need.
Yes, but you've also said that these things are being developed by trusts.
I think we are developing it, and we are getting more sophisticated, and there's more work.
But where's the evidence that you are?
In the work that we're doing around the mapping system, etc. I mean, if you're asking me, does the board have a 25-year or a 20-year plan for the shift in services for older people, then we don't have that at this point.
Does it have a 15-year plan?
No, we don't have a 15-year.
Does it have a 10-year plan?
We have Transforming Your Care as a direction of travel. The work is going on at the moment to look at what that means at local level, and I think committee members know that LCGs and the trusts are working very closely to translate, if you like, the TYC vision into local plans for the direction of travel. In terms of supporting people, we have the joint commissioning arrangement and we have the plan for the 18 and the 7. The work that I've described on the mapping system gives us a level of sophistication that we can put forward our projections of demographic shift, demographic change, to make a more sophisticated needs assessment, and that work's progressing as well.
Can I ask what the research project is called that you referred to in your opening statement?
At the moment, it is a proposal. I mean, I'm not aware of the exact wording on the title of the proposal, but
so this
is a proposal that we're seeking funding for.
So, how much would it cost if you? What is the proposal in terms of cost request?
Yeah, I can do that. The proposal for all 3 projects is around £500,000 over the next 2 to 3 years. We have some indications of support from an independent trust, and we have some early indications of potential government support, and we collectively are committing money to this. So we're putting the final pieces of the jigsaw in place, but it's around £500,000.
How long do you propose sorry, I'm not quite sure here, we're at the proposal stage. So how long does the project How long is, no, let's deal with it in sequence. How long is it going to take the proposal to get to some sort of stage of maturity and kick off?
We anticipate the Independent Trust is taking it to its management board in July, and we expect the proposals for the government element of that to be signed off shortly, hopefully shortly thereafter, with a view to, by September, being able to start to put in place the elements that we need to procure those services, with a view to having them next calendar year, the researchers in place to begin the work. So
that would start in the following. How long is the proposal proposed to take?
Yeah, overall, the funding we anticipate for the 3 projects to run for around 2 years. Not all of the projects will take 2 years. The Supported Living Champion, we anticipate that would be run as a pilot for around 2 years. The other funding, the other 2 projects, we need to bottom out the detail of the tender. Once we have the funding in place and we have the tender bottomed out, we'll have a clear idea of timescales. But typically, for research that we've been involved in before of this type, these projects take up to a year to from once a consultant or a researcher is appointed to final report.
So if I can just draw a timeline between when TYC was started and the conclusion of both a proposal and a pilot or a project, we're going to get 5 to 6 years. And that was twice the lifetime, at one estimate, of TYC.
Yeah, I mean, Sean will be in a better position.
I think you're linking this to TYC in a way that certainly isn't how I would have envisaged it. We have TYC happening. We have a planning process which TYC was cognizant of and was informed by. So TYC would have been informed by the developments in supported living that was being generated by the planning arrangements that Fionnuala has described. Now, that is a process that has evolved since 2003. It has evolved over that time. It has changed over that period of time. Fionnuala referenced a particular change that's happening to that that's not connected to the research. So it has been changing during the period that we've written TYC, published TYC, and are now working towards implementing TYC. And it is being further, hopefully, refined by these projects.
Yes, but that would be okay if decisions weren't being made elsewhere, vis-a-vis the policy objectives in TYC, which is why I read it out at the start. And for example, the Northern Trust simply shut down residential homes, believing that was consistent with TYC, yet nothing was done. So you can see the gap and the public concern that there is there. TYC says something, the Northern Trust goes, well, that's okay, we'll do that, and there's nothing there to support it. And now we're hearing that there's a project which may or may not get, I know you're saying you're hopeful, but I haven't heard you say it's happening, that you may or may not get the monies, and you're now beginning to try and assess. But decisions have been made, and then it had to be reversed. And I still don't know whether we're going to get admissions policy announcements soon around this very issue, and whether people are going to be able to retain in homes or have some vehicle for getting assisted living in the absence of alternatives. And we've highlighted today the absence of some of those alternatives because, for example, you've said that 99% occupancy in most of the 18 that are available. So a lot of older people don't have a choice right now, despite the churn that you say is in the system. So you can see where our concern is, and I think it was reflecting the committee's concern here in relation to a policy starts off. People have made decisions, and you're only starting to write the first page on how some of this might change.
Chair, could I just make a comment about the supported living, because I think it really is important. It might not be as sophisticated as everybody would have wanted, but then we have been in a process of needs assessment and planning around supported living for a number of years, hence the 18 and the 7, and that would have been incorporated into the thinking of the Northern Trust in relation to the future of their residential homes. So I'm not saying, I don't want to be drawn into that discussion about the residential homes, but certainly that planning was available. The Northern Trust was involved in that planning, and there were already, and I think Mr Beggs had referenced, there were already plans for new supported living facilities in the Northern Trust area, and they have been progressed. So the only point I'm making is there was a planning process. It might not have been as sophisticated as we would have hoped, and we've acknowledged that, but it was there. And
Yes.
it was informing TYC and trust decisions.
Or informed by TYC, and you've said that local trusts were making the decisions. And of course they're going to make a decision because they thought they'd cover to make the decision. Yet they didn't have a system to replace that decision. People are being reminded of a number of homes that were already closed.
Yeah, there are
Just
a
for
number.
information, the replacement supported living accommodation for the ones that were announced for closure.
Yeah.
But then others were announced for closure with no plans to replace.
So, in other words, you can see our concern. A plan exists with a policy objective. Things happen within that framework, and there isn't, and we're only now learning of frail plans, let's say, to move the situation forward. Notwithstanding other activity, I'm not saying nothing's happening, but we're dealing with it at a strategic and a policy level, and we're only now seeing some things beginning to happen, and some of them are ideas that came to this committee first.
I think that it is important to recognise that the planning mechanism that has been in place has been responding to a growing elderly population and has been meeting that demand fairly well. I think there is a difficulty between getting the balance between creating excess capacity that would allow for immediate exercise for choice and a financially sustainable model. I think that we have to plan for near full occupancy for these schemes, recognising that if someone wishes to move into them, you will have some availability, but they may also wait a short period of time before availability is there. If we were to create spare capacity, say, of 20%, that would not be financially sustainable for the housing associations. Now, our planning to date has delivered this. I mean, with the exception of one or two schemes, which I don't think were failures of the planning process overall, with specific schemes where there were particular difficulties, which, hands up, we want to learn from and find out exactly why that happened. But broadly speaking, the system that we've been using since 2003 has responded to a very significant increase in the elderly population in that period of time. I think that we want to get better and continually refine it. But I think that the arrangement that's in place is currently delivering on the shift that TYC signals.
Yeah, but I suppose, and this is one of the things that we've been looking for throughout and is consistent, is measurement. Mm-hmm. And people can at least, we can feel the pain of it and we can hear the narrative of it, but at least things can be defensible against measurement. And what we're not seeing is sufficient measurement in terms of assessing. So, for example, you have indicators of performance around Direction 2014, but we've no idea what would be a good number or a bad number. There's a number, and you're saying 155 is good for project, but how do we know if that's good or bad?
Well, I think I would go back to the plans that we've made. If it were a bad number, we would have significant voids or we would have significant waiting lists.
Yes, but we're encouraging people to go back to their own homes. That's the third part of the choice. You're now saying, before this, people lived in their own home and the choices were external to the home. You've injected a new bit into the equation, which is people living in their own homes. And of course, other people make assessment around whether that's appropriate or not. And you will say that they're doing that consistent with the plan. And we're seeing now from this evidence that people aren't necessarily getting the care assessment. So people are being encouraged to stay in their own homes, but are they getting the best in their own homes as well? And we don't know that. So there's a lot of things we don't know. And there's a lot of assessments I'm not here. I mean, if I was hearing it, I'd be able to say I'm glad to hear that. But it's sometimes what you don't hear in a meeting is as important what you do hear. And I'm simply not hearing an assessment. I hear things and judgments made on what you're saying about it's, both, that it's the both people, older people, and the value judgments that you're making around that. But I think we need to see measurables, some kind of measurements and research and understanding. You're accepting it, what I'm saying, because you're now starting to do it. But we have to ask, within the context of what you're doing now, whether you're actually doing now the right things, given that you haven't done it.
Again, I would come back to the activity that's been happening since 2003 has given us a situation where we don't have significant numbers of voids nor significant waiting lists. Now, that would indicate it's been a reasonably accurate way of assessing the need at the 115. I think that we want to improve it, and that's what we're aiming to do. But the evidence to say it's a bad number, I'm not sure it's there.
I would try. I didn't say it was a bad number. I said we don't know if it's a good number or a bad number.
Well, I would suggest that there's evidence to say it's not a bad number, in that we don't have large numbers of voids and we don't have large waiting lists.
Yes, but if they're not built, you won't have large numbers of voids.
If they weren't built,
if
they weren't built and there was demand exceeding the capacity, we would have pressure, significant pressure for places, waiting lists. We would have trusts saying that we don't have the capacity to meet the demand that we're seeing as we assess the needs of older people. And that's not what they're saying to us.
But if you're 99% occupied now, you can't offer people a choice.
As I said, there is some churn. And people will wait. You will sustain people in their own home. You plan for them to move into one of these dwellings or settings.
So are you doing a measurement about how many people are being sustained in their own home now?
Well, we know how many people are being sustained in their own home.
Who might otherwise need something else.
I couldn't give you that figure, no.
That's a very important figure, I would suggest to you. In fact, that's the most important figure.
Well, we certainly have a look at it. I'm not sure that there are people who are in their own home. They may have elements of their care package that they are not receiving, but if you're saying they're maintaining their own home because they can't access supported people,
is that a reasonable request?
We'll certainly have a look at it. I'm not sure that there is anybody in that position. Certainly we will take it away and we will have a look at it. It hasn't been drawn to my attention that we are offering the wrong sort of care to somebody in their own home because they can't access supported living. But I'm happy, Mr McKinney, to take it away and have a look at it.
But I think it's about the suitability, and I had asked that question about people who are currently would be suitable for a supported living facility and what kind of assessment has been done there. And I'm moving on, but what I'm hearing, Sean, is this word evolving.
Mm-hmm.
And that doesn't give me a sense that there's the forecasting, the modelling, the measurement outcome, the planning in place. And it seems to be very much an evolving process from trusts. So should, could, or what could the department do more in relation to this? What is the fit? Is the department doing enough currently? If not, what needs to happen?
And I think my answer has been that I think that the evidence there is that broadly we're getting it right with the plan, that the evidence in relation to the development of supported living schemes based on the planning model that we're using is broadly getting it right, but we're looking at ways of improving it.
Okay, I'm going to move it on to the issue of just the link between supported living places and statutory residential home places. And Mickey, you'd indicate.
Yeah, Claire Keaton, the Older Persons Commissioner, has told us that the availability of supported living will not necessarily reduce the need for residential places, because obviously our population, older population, is increasing. We've been told by 2020 it will have doubled. And there is an assertion in Transforming Your Care that the provision of supported living accommodation will reduce the need for residential. Now, for statutory residentials, I should say, the difficulty I have in my own constituency where there was a residential where Southern Cross were involved, and obviously they went down to Swanee at some stage, the Trust had to step in the interim. So there's always going to be that requirement. So, you know, they're two separate issues in a way, yet the department have linked them. You know, that because you're going to have supported living places, ergo you don't need statutory residentials. You know, and the waiting list and the non-admission policy is a big issue, because in my own constituency, one of the there's only one really in my own area, statutory residential left. Now that is working near enough at full capacity, and there would be people waiting to get in, but because of non-admissions policy at the moment, then that would not happen. So just really asking the question, one does not necessarily preclude the other. And, you know, why has that, you know, because if you look back to last April and May, the trusts were actually queuing to see who could close their homes first. The statutory residentials, because the Northern Tuscan and then the Southern and the rest, they all sort of jumped in, let's see who can get in first. And, you know, that's, I mean, maybe that's a cynical view, and I'm usually not that cynical, but it just seemed to be the...
Must have changed.
Yeah, I have. It's the company I'm in. Seriously, you know, it just seems that that's really what happened. And there was a public reaction, a public outcry, rightly so. And that's why it was changed. But the non-admissions policy is still an issue, and I think that's something that needs to be addressed. But it's really asking the question, why is it that linkage when, in a sense, they're two different issues?
Yeah, I suppose that what we're talking about in TYC is not just supported living, but a range of ways people can be supported in the future. We know that we've had a 5% decrease in demand for residential care across all sectors, whether it's statutory or independent. And you'll have heard us quote the number of vacancies that we have in residential care over a period of time. So as a concept of care, over probably, I would say, and I've been involved in this area of work for a long time, over maybe 10 or 15 years, even as long as that, the statutory side of the house, because of provision elsewhere, has started to diversify long before TYC and long before this recent debate and discussion. And they did introduce other services on the statutory residential side. So it's in the context of residential care overall that we will be planning for the needs of our population for the future. And as I say, a significant decrease in demand for residential care as we know it and as we provide it. It's very much communal living. It's not, if you've seen the supported living arrangement, it's very different in terms of meeting the accommodation expectations of the population for the future. Sean had referenced our ability through intermediate care and intensive domiciliary support to maintain people at home a lot longer. So in itself, it's not supported living that's making that shift. It's a range of things which has meant that the demand for residential care overall, I take your point about the independent sector market, and nationally there's work going on to get better at market predictions and forecasting, and that's a national piece of work because at the end of the day we don't want to be moved into a crisis situation where a home decides to close. At the moment, the capacity in the residential sector is significant. You're looking at probably 800 vacant beds in residential care. So, you know, we do have a lot of capacity in the system, and it's that situation that we have to have regard for as we're planning for the future.
But again, and I do accept there's a lot of diverse issues, but again, if I was a cynic, I might think that the reason there's been a decrease in the applications for statutory residential is because people are being steered towards the independent sector. And like, let's be honest, nobody will convince me at this point in time that transforming care isn't a shift towards privatisation to a greater or lesser extent, but certainly that would be part of the deal.
Well, we don't believe that in itself it is a driver towards privatisation. I think there are two important things to remember. The first is that we don't have statutory residential homes, in all our areas across Northern Ireland, and certainly even in the Western Trust area where there are still admitting permanent residents, there is a decrease in demand overall. So I think, and it's not just in the statutory, it's in the private and in the voluntary sector as well. And we do have the figures to demonstrate that over a period of time. We understand, as you know, I visited every one of the homes in this last consultation period, and I understand that people are committed to those homes, that the quality of care in them is highly regarded. A lot of them are vibrant hubs of service delivery. They provide a range of services that people need, step down, step up, intermediate care, rehabilitation. They are things that we are going to need in the future. The only bit of this jigsaw I'm saying is the demand for permanent living in residential care has fallen significantly.
Just to finish off by saying, in my own area, the statutory residential that's left is very much an integral part of the community. Provides care and very good care, but it's also very much an integral part of our community. And when you say some areas don't have them, the Belfast Trust closed their statutory residentials, but they did it in a very measured way, not putting out statements as Stephen Nolan show to satisfy his demand for what was happening. And again, without being too facetious about that, that's basically what happened.
And I think, Mr. Brady, the key in the movement in Belfast is that the alternatives were being developed, and that people were reassured that if there was a reduction in residential beds, it was consistent with demand and need, and that needs could still be met in other ways. And I think that that's the biggest communication issue that we have moving forward.
That's right, thank you.
Making sure that happens.
Okay, finally, the theme we wanted to pick up was just in terms of I suppose, the learning from other countries and also aligned with the use of the private sector. So I think Fergal wanted to raise.
Yeah. Has any work been done in that regard in terms of assessing best practice elsewhere?
We can certainly, on the housing side, a number of the schemes that have been developed have been national and international award winners. And Brian can touch on that. And certainly, there's been a suite of research commissioned by the Housing Executive in terms of housing for older people, national and international experiences. So there's very much been work there. As I think Sean has said, it's always evolving. We continue to learn, but there's a lot of work already being done.
Just to take the point, the committee have made it a number of times. We have commissioned over the last 3 to 4 years a suite of research on older people's issues. That's available, can make it available to you. And that's ranged from taking the individual senior citizens or older people's views themselves about what they want in the future, to commission research about what's best practice across America, Australia and Europe, to inform design issues around design standards, space standards, use of technology, to help inform the evolving process that we've referred to a number of times in terms of the journey we've been on together with the Health and Social Care Trust since 10 years ago in 2003 the programme was introduced. I think it's testament that the projects that you may have seen, be it Cedar Court or Sydenham Court in East Belfast, if you talk to those staff there, they will have had delegations from across Western Europe, from America, looking at design, looking at how they've integrated into communities. So in many cases, I think we fail to promote and recognise the quality of what accommodation we do provide. Part of it is also to inform some of the learning that we want to take forward in terms of design, role of technology, scale, and so that you learn it. So it's important for us in terms of getting the feedback, getting the customer experience, listen to the tenants, listen to other people themselves about what they want for the future, and that's part of that informing. There's a range of information from evaluation of individual projects to see whether that works, to help us inform the process. Some of it's about trying to speed up the process, because I think a number of committee members have made the point about how long it takes from thinking of a project to people being able to walk into it, and we're looking at ways of doing that as well. We've also recognised that we've not done enough around promotion, education, information, and one of the projects here is to do that, but increasingly at local level with Trust, I know the South Eastern Trust, we've done some DVDs around Cedar Court to get the message out, to promote that message, but also to share good practice as well, because we've seen a huge interest from a number of design and international competitions. So Cedar Court was nominated for an award. Elmsworth Court is likely to put in for the Dementia Gold Standard. And so when you look at the Dementia Centre in Stirling, they come over and have recognised what we do here is best practice and good practice. I don't think sometimes in Northern Ireland we're very good at saying that we do things well. I know the committee have characterised some of the process as evolving, and I understand why that may be a concern about that evolving suggests that maybe we don't have a game plan. It's evolving in the sense of using research evaluation to inform what we do and to do it better. At the local level, just to feed on what Fernanda was saying earlier, we have tended over recent years to bring all 5 trusts and ourselves with associations together in a framework. And maybe that didn't happen enough in previous years where the structures we have in place, so we're bringing that people together to share best practice, to say how you learn from things. There's still a big challenge for us. We really haven't got a good handle on the role of assistive technology and failed or dementia services. So we've commissioned research on that, but that commission research is commissioned to help us do some of what work better. I think maybe there's a lesson for us in terms of getting that research and that market intelligence back out to yourselves in terms of to see that we are trying to improve what we do and to listen to what the people want going forward.
Just with the last time the board was before the committee, I think it was the last time, we talked about other alternatives in terms of assisted living. The view was that sort of model tended to exist in sort of affluent areas in the south of England. Has there been any more study done of that? Given that, for example, there are other models in the north of England, for example. But has there been any more projections?
I would need to check. I thought that the reference to the kind of provision that was popular in the south of England was actually about campus village, retirement villages, as opposed to purely assisted living.
I didn't describe that, but I was talking about alternatives.
I can come in on that. The Housing Executive commissioned a piece of research in 2007 on retirement villages, which is published as part of this suite, and if the committee's interested, we can certainly let you have that. The view was at that time that while the concept was a good concept, Northern Ireland wasn't quite ready for it. So certainly the concept was there, it was explored, it was discussed with people. We've done a piece of research again more laterally that I've mentioned to the committee, where we did a survey of the baby boom generation, fairly small survey to get a sense of what people were interested in. Retirement villages and park homes were 2 things that people in that age cohort said they were interested in. So there may be a change starting to happen, but certainly there is some research already there.
Maybe can I just add on to that? As a result of that research, we've had discussions, conversations, maybe a better way to put it, with some private sector developers and some voluntary sector organisations who are looking to explore this concept. There's a major organisation who's talking to us about and have done some quite detailed planning and conceptual work around a retirement village. But a retirement village that fits and works here in Northern Ireland rather than in the south coast or the north coast. So there are interested in some of the larger private sector developers before the for sale market, because some of those baby boom generation will be homeowners with equity and would want to remain homeowners.
Yeah, it's some 70% of older people.
Absolutely, going forward in that age group.
Although not all homeowners would probably be in the market for that kind of development.
Part of it is a very niche market.
It is expensive.
Yeah.
Yes.
So I suppose from a housing perspective, we've done some research and evaluation to look at the concept and the applicability of the model to here locally to see what would work. And 1 or 2 of key providers, private sector developers and some voluntary organisations who have land banks, are talking to see whether that's a way to maybe niche market going forward. And you'll have seen in some parts of Belfast some of the private developers are marketing some of their new apartment developments as for 55 plus and trying to tap into that market. So one of the things that we probably haven't got across to you is that when we do look at what we're doing in the Western Trust with the Northern Trust, we do try to take account of what else is happening in the marketplace. If there's private sector development, if there's thinking about doing something else to inform us, because it would be not prudent of us to ignore what else is going on. But those pieces of research, I think, is a good example of showing some leadership to the sector to say, what does that look? And some people have taken it up. It hasn't matured into actual happening, but one or two organisations are at that point where I think they may be testing out planning applications in the near future.
So, sorry, if I can going back to your original question about international comparisons and what have you, I think it is important. Both Brian and Stephen referenced the Dementia Service Centre in Stirling, which is an international centre of excellence which provides advice on appropriate design and how the built environment can be adapted to meet the needs of people with dementia. And that's a service, that's a centre that we provide a financial support to, so that Northern Ireland can access a service from the Dementia Centre. The other thing is, I mean, just benchmarking internationally, there has been a few years out of date, but it estimated that only 1% of homes across Europe were barrier-free for older people, but countries which were in the 2 to 5% were identified as being progressive in regard to having a good provision, and the UK would be within that context. Now, Northern Ireland, my understanding is, stands well in overall UK provision. An international benchmark, we would be identified as being doing quite well. There are always going to be very innovative individual schemes in other countries which take very, very different approaches, and it's always worth looking at those and staying abreast of those. But as a national benchmark, the UK is seen as doing well across Europe, and Northern Ireland would be doing well within the UK.
Okay, and just one final point. Obviously, if the private sector are looking in on that, that would suggest that your figures, all right, I don't want to overlabour the point, but that there's some extra market there that would show a differential. That's all I'll say.
Well, I think that it is worth pointing out, I think that when you look at what the private sector are interested in, quite often it's a different kind of client. They'll talk about concierge services and assistive technology, and they're often targeting not only a very affluent group, but actually quite an able group who want to live with people of a similar age, but don't necessarily have the care needs that we're looking at in our 115 figures.
Okay, thank you. Thank you, Chair.
Okay, thank you. Well, folks, can I thank you for your time, and obviously from the committee's point of view, we'll be reflecting on all of this before we would make any recommendations, but I want to thank you for your robust responses today, and hopefully our robust line of questioning too. So thank you.
Thank you very much. And can I particularly thank our colleagues from DSD for coming along with us today. I think their contribution really added value compared to our previous appearance, which I certainly regretted because I don't like leaving here. I mean, I'm quite happy that sometimes we'll maybe not give you answers you want, but I hate not giving you answers, and that certainly was your experience of us the last time we appeared, and I think it's been very helpful having our colleagues from DSD here today.
Appreciate that. Appreciate your attendance. Thank you. Thank you all. Members, I'm going to move on, and I'm conscious of time and
You are now, are you?
conscious of time and quorums, etc. So I'm going to run through the business and then take the GP out of hours issue at the end. So moving on to item 6, which is a statutory rule, the optical charges and payments. It's on page 199. We had approved it on the 28th of May. Are members content?
Great.
Okay, if so, then I have to put the motion. The Committee for Health, Social Services and Public Safety has considered the optical charges and payments amendment regulations 2014 and has no objection to the rules, subject to the report of the Examiner of Statutory Rules.
Great.
Item 7 is the Forward Work Programme, which is on page 211. Item 8 is matters arising. 8.1 on 213 is a response from the Minister about services for patients with eating disorders. Are members content to note and copy the response to the Eating Disorder Association who had raised the matter? I'm asking members to note 8.2 and 8.3, which are on pages 214 and 215. Advising members that last week the committee considered correspondence from West Tyrone against wind turbines. The Environment Committee is currently doing an inquiry on wind turbines, and they are not looking at health impacts as it's outside their remit. Suggesting that this committee does not become involved in the issue and that we should write back to the West Tyrone against wind turbines and suggest that they contact the Public Health Agency with their concerns.
Yeah, great.
Agreed? Item,
Madam Chair,
Sure, yeah.
I understand that if there are young people who may be autistic living close to a potential wind turbine site, that is a significant issue which can be taken care of as part of the planning process. It's certainly been verbally passed to me by others. So there are some conditions that has been recognised, the flickering associated, which obviously could adversely affect someone with that type of condition. So there are some health conditions that are being recognised.
and is that something that the Public Health Agency should reflect on? And
Just it'd be helpful if they could clarify.
okay,
If they
okay.
could clarify, do they recognise that that is a valid concern? Someone who has
Okay.
a disability which is adversely affected by flickering, which is not that dissimilar from flash, flash
Okay.
photography, which is commonly known.
Happy to do that, to clarify that. Item 9, members, is correspondence. Asking members to note items 9.1 to 9.4, which are on pages 217 to 313. Item 9.5 on 314 is correspondence from Newry Mourne Visually Impaired Society, requesting that companion travel passes be made available. I'm suggesting members be write to the department to ask their views on the matter and whether they've discussed it with the Department for Regional Development.
Right.
Item 9.6 on page 315 is an individual case. I'm asking our members content to refer the correspondence to your constituency representatives.
Right, yeah.
And page 316, is a letter from Mr. Taylor
Well,
seeking a meeting with the committee about establishing a helicopter emergency ambulance service. I'm suggesting that the committee writes back to Mr. Taylor to advise him that the committee has recently wrote to the Minister about this issue and provide him with a copy of the Minister's response, which was considered by the committee on the 14th of May. And we can also advise Mr. Taylor that we've written back to the Minister for further details on the potential of the South's Emergency Aeromedical Service to begin operating on a north-south basis. So we can share that information with Mr. Taylor.
Yeah, Chair, the Minister did answer a question on that this week.
We did.
So on the north side, or the one with the air service, the joint one with the Republic of Ireland.
Okay, so are members comfortable that we go back to Mr. Taylor with that information?
Right.
Item 10 is any other business. Do members have any other business?
Just one item, Chair, if I can indulge. I've had correspondence from the Northern Ireland Rare Disease Partnership, about the implementation plan, which will be consulted on over the summer. There's a time scale here, and I appreciate we've done the speed dating approach to some issues, but I think this is a special case. And what they're looking for is the opportunity to present to members at a meeting, even outside of this meeting, if you like. If we could book a room, they could do a small presentation before we break for the summer. Rare diseases in themselves are rare, but collectively they're not rare and affect thousands of people, collectively, and their families, of course. So the consultation takes place on the implementation type will take place during the summer recess, and they're asking that the Health Committee agree to a short briefing meeting with representatives before the recess in July. I know that it's outside or out with what we've agreed around some of the other things, but given the implementation consultations taking place, it might be it's certainly arguable that we could have a short meeting, 15, 20, half an hour, before a Health Committee meeting before the end of the recess.
Can I suggest that, because I mean it is obviously an important issue, as are many issues.
Yes, I understand.
And I think we do need to be mindful of, an organisation suggesting that their issue is more important, and how do we measure that. But I think potentially the way forward on this is that if you or any member wanted to convene the meeting and invite, I know Kieran McCarthy did that recently in terms of some local issues as well, and invite the Health Committee members along that we could attend.
And could I liaise with you, Catherine, just in terms of accessing a room or something like that? Is that?
Would that have to be done? That would have to be done through, yes.
That would need to be done through the member.
Yeah.
Okay.
And I think then members.
I'd be happy to do that. And would you members be content if I did that ahead of a meeting? And that it would, at least that way it would increase the numbers.
Well, it's within your gift, your decision. they take that. But certainly then, if members are invited along, we can attend as we see fit.
Okay, thanks.
I think it'd be helpful just if you check that it isn't a meeting that we're scheduled to be away off site, or just check the diaries there's no conflict, or you know, perhaps we may have an earlier meeting planned at 1:30. So just get a suitable time, or else Monday and Tuesday, whatever suits.
Okay, all right, thanks very much indeed.
Chair, can I raise another issue just been brought to my attention? Children with eating disorders, there's a severe lack of provision of support services for children under 12. Could we write to the Minister, perhaps express our concern about that? We have a response here about patients with eating disorders, but children under 12, there is no direct provision. Children over 12 there is, but in those under 12 there isn't, so perhaps we would write to the Minister asking for clarification on what support and services are available.
Well, can I suggest that because we're going back to the Eating Disorder Association, who raised the matter generally about services, that we seek their views when we write back to them with the Minister's correspondence about the under 12s particularly, and then absolutely, Gordon, depending on the organisation or association's views, we can go back to the Minister.
Okay, we can live with that.
Thank you. Members, moving on then to the presentation. I just want to refer members to the briefing paper from the Department on page 191. I think Heather, unfortunately, had to go to get a flight, I understand, so apologies for the delay. But we have Stephen Galway here, Primary Care Directorate at the Department, and Dr. Sloan Harper, Director of Integrated Care at the Board. You're very welcome. So the procedure, 10-minute presentation, we'll open it up to comment or observation.
Okay, thanks very much, Chair, for the invitation today. I'm grateful to have the opportunity to provide evidence to the committee on the strategic framework for GP out of hours. We're just going to outline briefly the context of the framework and the main aims it's designed to achieve. So, GP out of hours is an urgent care service. It's for urgent primary care conditions that can't wait until the person's GP surgery is next open. It can only deal with primary care conditions, and it's not appropriate for people with, for example, strokes, heart attacks, fractures, etc., who should go to an emergency department or phone 999. Currently, there are 5 providers in Northern Ireland, 1 in each trust area. 3 are provided by the respective trusts, and 2 are provided by mutuals. So prior to 2004, GPs in Northern Ireland provided an on-call service to their own patients. However, after the introduction of the General Medical Services contract in 2004, all GPs opted out of that service, and then 4 health boards took responsibility for it. The department then asked boards to bring forward proposals for a more regional out-of-hours service with the potential to align the service more closely with other urgent care services. In the meantime, the Health and Social Care was restructured, and the work was then taken forward by the Health and Social Care Board. And the strategic framework is then the culmination of those efforts, and that's what it is today. So as part of the development process, a regional out-of-hours project was established, a project manager was appointed, and a steering group set up. An options appraisal was carried out and consulted on. The options appraisal identified a number of options, but settled on a preferred option for the out-of-hours service. This was the regionalisation of call handling and triage, development of a regional out-of-hours nurse triage, whilst maintaining the clinical GP service with existing providers. The service would be underpinned by a single telephone number. In taking this forward, there have been 3 aims. Firstly, to have a service which is patient-centred, effective access and demand management. To have learning and accountability organisations focused on quality and health outcomes. And thirdly, innovation and coordination. This is translated into 3 areas of work: simplifying access to the service, improving operational efficiency, and improving service alignment with other healthcare services. In terms of simplifying access, currently there are 5 providers, in fact 7 telephone numbers. So the development of a single telephone number would simplify patient access to out-of-hours service and help them access the most appropriate service for their clinical needs, and thereby improve their overall performance. or their overall experience of the service. The single number is also consistent with proposals contained in TYC, Transform Your Care, which recommends a single telephone number for urgent care in Northern Ireland. Other mechanisms to simplify access would include improved communication with the public and better telephony to manage all the call handling workload across Northern Ireland. In terms of operational efficiency, there have already been significant enhancements in technology for the service, which the board will continue to build upon. For example, a website for GP out of hours is now in place and is intended to improve the service further through enhanced technology intended to coordinate and facilitate visits and to coordinate workload amongst call centres at busier times, as well as consolidating the number of triage centres at times of low demand after midnight. In terms of improved alignment, this would include, for example, agreeing protocols with the Northern Ireland Ambulance Service in relation to the transfer of calls to and from them, and would also include consideration in due course of further broadening the service provision to cover call handling for social services and mental health. Based on the preferred option identified in these broad areas of work, in April 2012, the Minister agreed that the Board should go to public consultation on the strategic framework. The committee was informed and copies of the strategic framework and consultation documents were supplied. During the consultation period, the Board held 9 meetings to take views, and at the close of the consultation period in December of 2012, had also received 50 written responses, including 1 from the committee. These responses were collated into a summary document, and the strategic framework was revised by the Board, taking on board comments received. In January 2014, the Minister agreed that the Board could release the revised framework and the consultation response document to those who had responded to consultation and other key stakeholders, including the committee. The key message from both the engagement with stakeholders and consultees is that a broad support for the strategic framework and the direction of travel. Now that that direction is set, the Board will lead on the implementation of it. An outlying timeframe has been set, and this first significant milestone is the scoping of the single telephone number for September of this year. As part of that work, officials are monitoring the position in relation to NHS 111 in England and in other parts of the UK. However, it is crucial to note that a key difference between what is happening in England and what is proposed in Northern Ireland is that in England, triage is carried out by non-clinical staff, where in Northern Ireland, triage will continue to be delivered by clinical staff. I should also highlight that all of the detailed proposals which will be developed under the aegis of the strategic framework will require a robust business case to justify any additional funding that might be needed. There are also a number of other challenges apart from funding which will need to be tackled, not least how to manage demand at peak times, how to recruit and retain staff, how to ensure the service delivers of high quality whilst any new arrangements are put in place. What's clear is that out-of-hours provision is known about in Northern Ireland. There's a high level of public awareness, and usage here is significantly higher than in England, Wales and Scotland. We also know from surveys done by the RQIA, PCC and Ipsos Mori polls that is well regarded by service users. So it is a case of building on what works at the moment, but making sure that it is as easy to access as possible, runs as efficiently as possible, and fits coherently in the wider landscape of urgent care provision. So I hope that's been helpful for the committee, and we're happy to take questions.
Thank you, Stephen. Was one of the things, just in terms of your paper, that jumps out is the number of patients that are using GP out-of-hours services has increased by over 18% in the last 5 years, whilst emergency department activity has decreased some 2% over the same period. But the committee has consistently been told that a large part of our problem associated with emergency departments is that it's more and more people.
Well, I suppose it's not just about there is the number of people, but it's how they're managed and how they're dealt with and triaged and assessed. Some of the patients that attend out of hours may be directed towards emergency departments, but some of them may be advised to come back, to contact their GP the following day or to see a doctor that night. But as well as at emergency departments, it may well be around not just the number of people, but how they're managed when they're there and accessing emergency departments.
But I think, and I know this isn't necessarily your remit in this, but consistently we have been told that it has been an increase in people turning up at accident and emergency, which was referred to on many occasions as anything and everything, and the increase in our elderly population going through emergency departments. So effectively what you're telling us is there's actually been a 2% decrease over the last 5 years.
From the data that we've pulled together in terms of this, yes, there has been.
Okay, thank you. Yes.
Maybe, Chair, I could add to that in terms of some of the details. So, absolutely right there. It's slightly less than it was 5 years ago, flatlining or slight decrease. That's a regional figure, and within that figure there are differences in the 5 different trust areas.
Okay.
So in the western, southern and southeastern areas there is an increase in numbers, but in the northern and Belfast trusts a decrease in attendances at emergency departments, which outstrips any increase in that.
So
other
the
area.
northern and Belfast, there's a decrease?
Correct, yes, that's correct. But at individual hospitals, they may see an increase because of a change in the number of emergency departments.
Oh, okay. And very interesting.
Yeah.
Thank you for clarifying that. Just in terms of the framework itself then, does the department know currently whether it can afford to implement it?
Well, I think part of the framework, as I said in the opening statement, really is that there are certain elements, building blocks within the framework, so each of those has to be brought forward. For example, the single telephone number, and it's only through the business case process we'll be able to determine what level of funding it is to provide that. But it's looking at the overall budget that we have for out of hours at the moment, what aspects of development that we need to put in place, and how much that's likely to cost.
So it hasn't been costed?
No, not each of the individual items that would be needed. I mean, there's been a financial review done of out of hours as it is at the moment, but in terms of going forward, there's obviously there's no firm estimates of the cost attached to individual areas of work, but that will be taken through as part of each element in the business case for each area of work that we want to do.
Okay, well, just by way of, I suppose, the timeline. We had the public consultation you referred to, Stephen, and the responses ended in October 2012. Summary of the responses, November 2012. Yet it wasn't until January 2013, which is 13 months later, that the Minister gave the approval for the implementation. What was the cause of the delay?
I think there wasn't any specific reason other than, I mean, it was just being aware of what the board were putting through in terms of the consultation, looking at it to ensure it was the right direction to travel, but also taking account of what was happening in England. There were obviously an awful lot of issues around NHS 111. What did that mean? It was a single telephone number, just making sure we got that correct, that we weren't going to go down the same route. So any issues that have been sort of highlighted through that development and implementation in England, Scotland, that we would be aware of those. And obviously then the Minister had some individual queries that he wanted clarification for, and it's just back and forward. So there wasn't any specific reason, but it could have probably been done a lot earlier. But that's.
But has there been any impact then? If there's no specific cause, has there been an impact of the delay?
Well, there probably has been in terms of, I mean, we would have been a wee bit further ahead than we are at the moment. But I mean, the steering group is reorganised again. It's the meeting this week, and everything in terms of, there has been in the background work going on in terms of the single telephone number aspect. Members of the steering group have been working away, closely involved with England, what's happening there, looking at how that business case can be developed. So there has been possibly slight areas of delay, but I mean, there also have been in the background and running alongside work that has been going on, so it hasn't been a total loss. So.
Okay, just finally for me, one of the issues around, again, the whole Transforming Your Care agenda has been, I suppose, highlighted through the likes of the Royal College of GPs.
Yes.
That the shift left hasn't been supported by a move left in terms of investment for GPs, and that the participation, for want of another word, through general practice has increased dramatically, but that hasn't been followed by either investment or the fact that we are now looking for the system at that community intervention, early intervention level to do more. How do you respond to that criticism? Is that accurate?
I think, in essence, I mean, it's outside of out of hours, and you know what we're here today to talk about. But I mean, in terms of TYC, I think there is a move in looking at identifying that funding that needs to shift with it. I mean, there has been an awful lot of work done in terms of integrated care partnerships, designing individual funding for those, for the development of those, making sure that they're able to operate, and poster backfill to allow GPs to get closely involved in the development of ICPs and the care pathways that they need to develop. But I think there is a plan in terms of with the department that money will transfer with that workload. It has to be able to support the work.
But I think it is linked, Stephen, it is linked if we're looking at out of hours services and almost with a view to taking some of that focus away from emergency departments, you know, when people are in more drastic need, if you like, or more need for intervention. So it is linked to that process. So I'm just interested in your thoughts around how that system is supported. I think you maybe
I could add that,
Yes.
Chair. In 2013-14, the board invested an additional 1.05 million in the GP out of our service, which it is coming under strain. And as doctors, it's the same workforce that work during the day that we require to volunteer to work in these services at night. It's not a different service. So as they get busier during the day and the changing nature of the workforce, in medical students, higher numbers of female doctors, so it does put this system under more pressure. We put additional funding in 13-14 of some 5% extra, and as part of the 160 million which has been bid for as additional funding for 14-15. 2 million of that would be intended for GP out of our services to boost numbers. But as I say, that you can only stretch an elastic band so far, and a medical workforce planning group is looking at the numbers of GPs that we train in Northern Ireland. Previously 60% male, 40% female. Now those ratios are reversing, and that has an impact as female doctors look to family-friendly hours and so on.
Okay, I appreciate that. A number of members had indicated. Gordon first.
Thanks, Chair. Just a couple of quick points. What are the advantages of the new phone system over and against what probably was a more localised system that exists at the moment? Sitting here, you would think, well, we're getting into a huge organisation. People are going to join queues. They're going to be probably talking to computers, not to a real person, and have to sit for some time while they're trying to obviously get a response to their medical need. Is there a risk here of going backwards rather than making improvements?
There's always a risk with any system, but provided you look at evidence from other places, and we've looked at Scotland where they have NHS 24, which is a single number. It's a difficult number to remember, so they are moving to 111 in Scotland, and that works well there because they have what is called virtual telephony network. So jobs not having to move out of local areas, but a telephony network where every receptionist who's taking a call can see all of the calls in the system, and they can be taken off in chronological order. Whether receptionists were working in Derry or in Belfast or in Armagh, they can deal with demand from the whole of Northern Ireland, and that makes the system more efficient and effective. And you should be able to get through quicker, and we should be able to monitor that better as well. So
it'll be one centre.
No, different centres. So keeping the workforce in their local areas, but they can all be linked in one telephony network, so that they're all linked up by computer. That's how it would work.
If the demand is higher in one area, another area where demand at that point of time during the night is lower, they can take some of the pressure off by addressing the calls and triaging them accordingly. But it'll be dealt with primarily in the first instance in local areas.
Local areas, right. And is it the intention to go out to an outside provider to provide this service?
There's no plan to do that at this stage. There are a number of options, one of which would be a procurement. Another would be to go to a trust. We have the Regional Ambulance Trust, which has a telephony network. That's another possibility. Or one of the existing providers who have telephony systems where they run or they receive their calls. Nurses operate those and ring patients back. So there are different options, but there's no specific plan as to who the provider would be.
Okay, just the GP contracts, are they under review?
The GP contract is negotiated annually. So, general medical service provision during the day.
I mean, out of hours contract?
Out of hours contracts.
Yeah. Well, the doctors who work in the GP out of our service are a mixture of salaried doctors and doctors whose services are retained on an as and when required basis. So their pay since the initiation of this service back in 2005 has been linked to the consultant contract. So uplifts which are applied to that then should be applied to the doctors.
They will be, or are?
Well, they should be. If they're not, we
will continue. They do tend to be quite overloaded. So what about managing the demand? How are we going to do improvements to that to help manage it?
Well, as Stephen said, the advantage of one single network is that you can use all of your capacity all of the time. So if the centre in Derry is under pressure, but Newtownards is not under pressure, then the staff down there, because they're linked through the telephony network, they can come in and assist with some of the pressure. And that's the way it works in Scotland. You know, the big centre there is in Edinburgh. But if there's pressure on air, then the Edinburgh folk can come in and assist with the triage of calls. They bid for funding, and that's dependent on the 160 million coming through, would significantly improve the number of doctors available and the number of nurses as well.
You're sharing the workload then?
Sharing the workload across Northern Ireland. And to do that effectively, you need what's called a directory of services. So you can ensure that someone who's doing triage in Belfast understands whether pharmacists are open in Strabane or Roma, can direct the patient there.
Yeah.
Yeah, so there's some management with that.
I still think people will be concerned about moving away from the local service. You know, in the Northtown area, we're stuck in with the folks over there in Ards.
You're in good company.
And we have to go to Newtownards. But and there is a risk, of course, that, as the chair was saying, that people don't go. If you're living in Hollywood, you're going to go over the hills to A&E, rather than travelling away to a far-out place like Newtownards. So, you know, this is an issue as well. You know, and it's trying to change those trends is going to be difficult.
Well, there are certain core principles in the GP out of our service, and one is that doctors will continue to do home visits. So to do a home visit,
They still do home visits, doctors, they do?
Yes, they do. 7% of the contacts result in home visits.
Is it only in the middle of the night to do them, is it?
They must do them sometime, I'm told, sir.
But
for example, at the minute, if you live in Armagh and you phone up, you're actually speaking after midnight, you're speaking to somebody in Ballymena. But if you need to see the doctor or be seen at home by the doctor, it will be a local doctor you'll see in Armagh, or they do a home visit.
What's the response time? Is it a week or no?
We do monitor the response times, and we divide the calls into urgent and non-urgent. And for urgent calls, getting back to the patient within an hour is the target. So that is 90 to 95% achievement. Where we're slipping and we're concerned at the minute is the level of delivery on the non-urgent, because a headache that appears to be non-urgent may then develop into something. And in a couple of the areas where they're having difficulty getting doctors to work at night, and over weekends and bank holidays in particular, the non-urgent response times have become unacceptable. So we're visiting those providers in the southern and western areas, and we're testing a pilot in the western area, which will involve extended hour surgeries by GPs. So they have agreed, the majority of doctors in that area have agreed to extend their opening time beyond their contracted 6 o'clock. and that will allow the out-of-hours centre, when they get the calls, to send the patient to their local surgery. So we're testing that over the next month. It should start in the western area, and then we hope to extend it to the southern area. And those are the two biggest recruitment and retention problem areas at the minute.
Will that be extended out across the province?
Yes, to the other areas as well.
We're likely to see our GPs with evening surgeries again?
That's what we hope. That's what we plan. They're not compelled to do it because their contract says they work up to 6 o'clock. But with additional investment and additional funding, then we believe that there will be a good level of interest in this.
Has this been driven again by transforming your care?
Driven by concerns just about the out-of-hours service and the level of pressure on it and the difficulty of getting doctors who are in their surgery. They're staying there to 7 or 8. You may not see them as a patient at that time, but the work they do on tests and diagnostics and so on, to get them to sort of go straight from the surgery into the out-of-hours centre and work to midnight, or it's becoming more and more difficult to secure that.
No, I appreciate on talking to our doctors, in the trust area. We as MLAs think the doctors are not that busy, but when you go and talk to them and spend some time, you realise they are busy people. So it'd be interesting to see how you're going to manage to get them to reopen their evening surgeries, which I think is a positive thing and is something should be certainly explored.
I think the other issue is patients who are discharged from hospital at weekends and bank holidays. Traditionally that hasn't really happened, and with the pressure on beds, we need to keep the flow going through the hospitals, and that helps the emergency departments. The whole system is connected. And for the staff in hospitals to have confidence that when they discharge a patient on a Sunday afternoon, that patient will receive maybe a booked visit that evening. And that means more capacity within GP out of hours, because in those circumstances they're not acting as an urgent care service. It's a planned visit regime, intermediate care we call that, and we need to make investments to make that happen as well.
Okay, thanks very much. Thanks, Chair.
Thank you. Roy?
Yeah, thank you for your presentation. And in the information you've given us, you told us that the service in 2012-13 was costing some £21.6 million approximately. But you've also indicated there's quite a variety of costs per head and per call. The call costs from 36.65 to 49.75. That's about a 33% variation. It's quite large, and the cost per head from 10.18 to £17.34, and roughly 70% variation. Can you account for why there's such a large variation in cost? Is it Belfast urban against rural travel distance? So what's the reason for these variations?
I'll take that. Yeah, I mean, the rural-urban thing is a big part of it. If you're in the call centre in Forestside, most of your calls will be within 5 minutes drive, whereas if you're in Causeway and you get a call to Torhead or Glens of Antrim, that takes the doctor and a driver out for a couple of hours, up to a couple of hours, dealing with that. So you need more drivers, more cars. You need 3 where you have 2 in Belfast, and that accounts for up to 50% variation. The way that the organisations run their work and secure the services is a factor as well. We allocate funding for out of hours, and we hope that it's all spent there. We presume it is, but there might be some variation in the efficiency. So the western area has 5 centres, whereas the northern area, with a bigger population, has 4. And that was a legacy from the previous boards, and also reflects the fact that the western area has bigger distances, and you can only have a certain distance if doctors are going to go out to people's homes, or you expect people to come from their home in the middle of the night into a centre. So those sorts of variations account for the difference.
But you see some efficiencies coming in your new model?
Yes, well, certainly with the virtual telephony network, there is the potential to not have to staff up for the maximum level of demand in every centre all of the time. And currently that's what we have to do. You know, it's reasonably predictable, but it can take off unexpectedly.
And finally, Gordon mentioned the nature of the contracts. I had the experience of using out-of-hours services and describing what exactly I needed. I was a minor operation in my back, and I was told I may need a couple of stitches removed over the weekend because of infection. So I went to out-of-hours services. Yes, come in. So 2 hours later, I went into out-of-hours services, stripped off, showed them my stitches, and agreed, yes, you needed 2 stitches. And the doctor then told me, we don't do that. Are you looking at the nature of the contract so that doctors don't send patients to A&E because of really basic issues because of the nature of the contract that had been awarded? Yeah. So I felt I didn't have something that warranted accident emergency. Yeah. But that's where I was sent to by out-of-hours services.
I appreciate that. So, I mean, that would require the urgent nature of the service to change, and it becomes more like a primary care service out of ours. And we do need to do that because it's not appropriate for something like that to go anywhere other than the community.
So are you reviewing?
Yes, we're reviewing. So we're reviewing the alignment of GP out of ours with all the other services, not just something like surgery, but also mental health services, and also the protocols with the ambulance service as well. You know, there are people being taken in ambulance who could have been dealt with, their problem addressed by the out of hours. And developing protocols with the ambulance service is something we've already started. We got one agreed last week. So there are elements of this strategy which we're already implementing. And we've implemented a consolidation of the servers. Each of the different providers has or had a different computer server, and so you couldn't link them up, and you didn't have the potential to have a single number. And as well, when they went down, you know, the support for the servers wasn't as good as it could have been. So they're now linked into the main health and social care server based in the Royal and City hospitals.
And just for clarity, I wasn't concerned about my treatment, I was concerned about pressures on the street, pressures on the nature of the contracts currently generates.
Okay, thank you, Roy. Fergal?
Yep, just a couple of points. I mean, I assume this is about driving efficiency, if you like, in the process, but also about removing pressure in terms of A&E. So it would be a priority strategic framework.
Yes.
So why, and sorry, how much does it cost? I know you've said that the framework does not contain an assessment of the cost of implementation, but in a ballpark, what would that be?
It really is difficult to say. I mean, in terms of it's the infrastructure you're going to put in place. We've already put in the regionalisation of the consolidating the servers, as Sloan has said. But then the telephony system, it could be anywhere. It depends on how you provide that service. Is it run as a contract? Is it provided by in-house? It depends on where you get it from. So it's difficult to say. I mean, in terms of the actual funding for out of hours, I mean, Sloan has mentioned earlier, we've already put in 1.9 million. There's another bid for 2 million as part of the 160 million. So that's gone in to try and, as part of the 160 million deficit, 2 million of that is for out of hours. That's to provide greater funding.
So not only is it subject to availability, the funding isn't there.
Well, the funding is there at the moment to provide the service as it is.
No, I understand that.
Yes.
But sorry, no, obviously, what I mean is the overall objective of this is to streamline the system, to take the pressure off A&Es. We're seeing all of those pressures erupting, and yet, and you might expect that's a high priority. I'm not putting words in your mouth. Maybe you could tell me, is it a high priority?
Well, it is a high priority, but as we mentioned at the start, from the level of activity at out of hours has increased dramatically, so it's already taken pressure off emergency departments as we see it. But yes, no, the funding in terms of delivering strategic framework hasn't been either formally down into detail or secured to drive it forward. But given that it would be a priority, then it would be hopeful that the funding would be secured for it to support it.
And what's the category under which it was bid for?
I don't have that with me, but I can find that for you. I can get that.
But is it consistent with its importance, or is it somewhere down the list?
I'll check that for you. I'll get that information for you.
Okay. But you can see where I'm to travel here. We're seeing a project that, on the face of it, is a high priority, strategic significance, may relieve A&E pressures, and of course that would reduce some of the costings with A&E, and yet the money's not available, and we don't have a sense of how much it would cost. So I don't know that there's much more to be said from my point of view, but those are some big question marks, really.
Maybe I could add, Chair, just on that. So the funding to consolidate the servers was capital funding, so around 700k was spent on that. In terms of a virtual telephony network, the capital requirement would be less than $1 million. What you have to do, rather than just get the tin boxes and bring them in, you do have to ensure that your organisational arrangements are in place, and that would require discussion with the staff side as to how it would affect staff in the different centres. And I think that's the thing we have to be careful about.
Yes, but if you're getting your ducks in a row otherwise, you're spending money on capital, both for the servers and the telephony, whatever. But then if you can't find the resources elsewhere, then what's the value of the money that you've spent? It may be able to be used in the future, but obviously there's some big question marks hanging over whether this will be implemented or not. But I think that raises some other bigger question marks over, how consistent is this with the overall plan, and why is it not being prioritised from a funding perspective?
Okay.
Yes.
I think on that, it's a matter of getting through the business case process and submit that to the departments who are working through that now. But I say the sensitive negotiations with staff is something that does take time and we can't rush.
Thank you,
Okay,
thank you, Chair.
thank you, Fergal. Yeah, Kieran?
Yeah, Chair, thanks very much. Again, I share the concern of other members around the table about the working of this new start. When will it kick in? And I can remember, I think you said 2005 was the initial out-of-hours service provided, and I can remember well the enormous kick-up and hiccups that were around that service for a long, long time. Are we in for another area of time and when it just doesn't work, and public representatives will be inundated with complaints, etc.? The telephone staff, will they be qualified people? I mean, you know at the moment whenever you ring up, as I understand it, that the telephone people ask what's wrong and all the rest of it, and that has been very frustrating for a number of patients, in the middle of the night. Will these people be qualified to say what's wrong, come in or stay at home or what?
So if I could take that, Chair, the call handlers are trained. They're not clinically qualified, most of them, but they are trained to deal with the public. They take the details, they record it on the computer system, and it goes through then for triage. So that will either be a callback by a GP or a nurse, always by a clinical person. If you bring in any new system, you have to ensure that you've done tremendous communication with the public. But if we were doing this, it would be an easily remembered number. And we have over the years received a number of complaints or concerns by someone who lives in Cumber, and they go to visit an elderly relative in Enniskillen, and the elderly person is unwell, and they simply don't know how to get in touch with out-of-hours over a weekend, whereas with this new system there would be an easily remembered number. So we think it will be safer, more responsive and more accessible.
When's the kick in? When is it going to kick in? Or is this all dependent on the funding, as the Fergal has been inquiring about?
It's certainly dependent on business case approvals and so on, but we are putting this on quite a long project period because of the sensitivities and because of concerns that people have with change to this service. So the initial plan would be to look at the red-eye period when the number of calls is quite small, and to move that over and then extend that gradually to the rest of the evening and weekends. But 2016 for the red-eye period, and then 2018 to 2020 for the remainder of the out-of-hours period.
So we're going to be saddled with what we have at the moment, good, bad, or indifferent, until 2016.
2020.
Okay.
We'll press on this as hard as we can, but the sensitivity of changing something which is stable and is working pretty well. It's far from perfect, but it's well received by the public. There's about a 75% satisfaction rate. So to change that, you need to do it carefully and do it safely.
And if, the June monitoring bid is successful, how much of the system will that actually impact on, or how much can be implemented in terms of this new framework?
Well, the majority of the money in terms of due monitoring is to provide additional funding so as there can be increase the level of GPs who will come in to provide the service. So it's providing a better resource level within the current setup of out of hours. So it's not paying GPs more; it's providing more funding to allow more GPs to come in to help with the service, to manage it, the demand. It wouldn't have a direct impact in terms of the strategic framework as such, because obviously those elements will have to be dealt with through a business case process, but the money in due monitoring is primarily for that area.
Yeah.
Okay. Okay, sorry, Kieran.
But no, just to put on record, I just hope that at the end of the day, the patients will be better off through this system that you're talking about, because at the end of the day, it's the patients that we all are very much concerned about, rather than saving a few pounds here and there.
Oh, very much so. And you know, where we've seen it working before in Scotland, in England, it's not always perfect, and England made a change from NHS 24 to a different organisation, NHS 111, and that wasn't without its troubles, so we've learned from that. But as Stephen said earlier, our triagers, the people who deal with the public, will be clinically qualified. But you know, I can say, having seen the system in NHS 24 in Scotland, it works extremely well because they actually use it as a 24-hour service. So when a public helpline has to be put in place, for example, pandemic flu, they can get messages out very easily to the public 24 hours a day, not just during the out-of-hours period. So, you know, when there's a worry about a medication or a drug, a side effect, that sort of thing, and people are concerned, they can act as a helpline for the public. And that's something I think the public in Northern Ireland would benefit from.
Okay, thanks.
Okay, and finally, Sam.
Thank you, Madam Chair. Thank you for your presentation thus far. Could you tell me, are there any GPs at the moment working 6:30 to 7:30 in the evening to relieve the pressure on the hospitals?
In the eastern area, there have been a number of initiatives around extended hours opening for surgeries, but only in the eastern area.
Right. Well, I welcome that, and I would encourage it, because it will ease the situation at the hospitals, because if somebody cuts their finger, they have to go over to the hospital or to go to their GP. When you talk about GPs going to consider it, that wouldn't be every night of the week, surely. It would be stipulated night, say a Wednesday or Friday or something like that.
That's right, that's right.
But I would welcome that, but could you tell me when it's going to be implemented?
Well, the extended hours opening, which we're starting in the western area, should be starting in the next month to 2 months.
Could the Craigavon area come in on the 3rd month then?
We'll look to that. Yeah.
Would you please note that?
Yeah, we'll seek them.
Upper band.
Yeah, we'll get you there, sure. I think the important thing is the experience of the Legacy Eastern Board was that when they ran evening surgeries, sometimes it was the same people who were there during the day who were booking into the evening surgeries, which wasn't really all that helpful. You know, it's people who are busy working. They can't get to their doctor during the day out of work, so the extended hours opening would be for the out-of-hours centres to slot people into their local surgery. So it really would help the EDs.
But your local surgery will only be certain nights in the week, it'll not be every night?
It'll not be every night.
It'll be mainly midweek and maybe a Friday or Saturday evening?
Tuesday, Wednesday, Thursday.
So not the weekends?
Possibly weekends as well.
That's when the hospitals are bummed more with people going in, either being drunk or something like that. You know, they don't need to go to the hospital to get sorted out.
Yeah, so we're in negotiation.
I welcome the move now, I really do. Thank you.
Okay, folks, can I thank you both? I mean, obviously, from the committee's point of view, it's hugely important framework. However, I mean, I think you've heard the issues that are raised here in terms of the costing, the delay in the process to date, the shift left, and the lack of resources there. So I would request that we get access to an update as this develops, and particularly in terms of the business case going forward, and literally how it will be progressed over the next number of months. So thank you for your time today. Members, just the final item is the date and time of the next meeting, which is on Wednesday the 18th of June at 2 p.m. in room 29. Thank you for your...
This is the Northern Ireland Assembly Committee Room, 29.